Good morning. Last day. So welcome everybody. My name's Mary Lynn Mathry. This is the 15th National Clinical Conference on Cannabis Therapeutics. Last day, Saturday. The theme this year has been the endocannabinoid system and beyond. So yesterday, for those, and Cola's joining us. Yesterday, for those of us who were here, it was kind of one of those heavy, heady days of a lot of information coming in. For those who've registered, don't worry, we will get this available to you online so you can have a period of time to view it a little bit more. It is too much to grab in one day. Today we go focus a little bit more on clinical aspects. So it's a little bit, I think, easier to digest for a lot of us. So I want to make sure you knew that. The other thing, everybody to know, once again, those who want continuing ed credits, online or here, hopefully here, you've got the paper that's from the University of Virginia School of Medicine, School of Nursing. Together, they are jointly sponsoring this with the Academy of Cannabis Education. Patients Out of Time is transferring our legacy of the conferences to the Academy of Cannabis Education, which will carry it on. We'll focus more on patient education. Anyway, to do this, on the back, or the last part, has how to get the CEU credits, or CME credits. So please follow the directions. We want you to fill out an evaluation, which really helps. If there's certain topics you want covered, we want to know that. So please don't forget that. Again, for those here, please visit the exhibits downstairs. A lot of information. Our bookstore, a lot of information. And the good news is we've got some authors here in case anybody wants a book signed. All right, so to start the day, we're going to have Dr. Marion McNabb coming from Massachusetts talking about a health provider medical cannabis study that she has done. So let's bring her on.
Good morning, everybody. I hope everybody had a great night last night and good conference so far. I appreciate you coming for the first presentation of the morning, so we got our early birds here. My name is Dr. Marion McNabb, and I'm the president of the Cannabis Center of Excellence. I'm really honored to be here this year presenting some work that Mary Lynn is a co-investigator on. So just very quickly, the Cannabis Center of Excellence is a 501c3 nonprofit based out of Massachusetts, where we bring together citizens, medical patients, academics, researchers, community members, healthcare professionals, policymakers in the industry. It's a lot of stakeholders there. But the goal is really to provide a virtual place to house best practices and to advance cannabis research, education, and social justice programs. In addition, highlighting best practices for the industries, both the healthcare, education, academia, and cannabis industry. So some disclosures. I'm the president of the Cannabis Center of Excellence. I'm also the CEO of 510 Innovations, which is a medical cannabis and entheogenic medicine data science company. I'm a cannabis advisory board member for the Massachusetts Cannabis Control Commission. I'm also an unpaid advisory board member for Cannabis BPO, which is a member of PharmaCentra, and then an unpaid advisory board member for Elevate Northeast, which is a community education nonprofit. So I'll give a very brief summary. I started conducting cannabis research studies in 2018 together with UMass Dartmouth. We started in 2018 with a cannabis consumer and a patient study asking generally cannabis consumers and patients, why do you consume cannabis? For what health benefits are you seeking relief for or adult use? Following the 2018 study, I used a similar study tool, but revised to fit a veterans population. So in 2019, I ran a veterans health and medical cannabis study, asking again why veterans consume cannabis, how does that help their health and wellness, and what kind of barriers and facilitators they have to accessing cannabis. And then in 2020, when COVID hit, UMass Dartmouth and myself as the principal investigator launched a COVID-19 impact study on cannabis consumers and patients. And so what this graph is behind me is in all those 3 studies, we ask consumers and patients, where do you get your information about cannabis? And this slide shows the majority of all of those respondents in those studies really seek their information about medical cannabis from a mobile application or a website, a dispensary agent, a Google search, scientific literature, a friend, and then a healthcare provider. So, and then following the cannabis cultivator. So we can really see that, there's a real need to, work with our consumers and patients to link our healthcare providers together. And as a result of that finding over the last couple of years, a group called Medicinal Genomics reached out. And they asked, we want to know what do healthcare providers now know about medical cannabis. And so we launched the Healthcare Provider Medical Cannabis Knowledge, Attitude, and Practice Study. It was launched in May 2021, and the data that I'm presenting today was up until May, analyzed up until May this year. We have 354 providers that have participated, and the study is still ongoing. So if you'd like to take the survey afterwards or share with your networks, we greatly appreciate it. And again, the study is led by the Center of Excellence, Medicinal Genomic in UMass Dartmouth. However, was very intentional about inviting co-investigators to be a part of the study. I'm a public health doctor by training, not a medical doctor. And so you can see here the list of the co-investigators on this research study. They helped design the study instrument, have helped to get the word out about the survey for their colleagues to take it, and advise on the preliminary findings of the study. So the methods that we used, this is a population level convenient sampling approach that we used to collect the data. And as you all may be aware, federal restrictions and restrictions on research make it difficult to find large swaths of funding. And so we've been very creative about how to, one, get the word out about this study and think about different ways and approaches of collecting data. So as part of these methods of collecting data, we basically have made yard signs and have distributed yard signs with QR codes and placed these around hospitals, mainly around Massachusetts. We've done social media blasts and email blasts with our colleagues. And then over the last year, I and several colleagues have been on the ground advocating and raising awareness about this research study at several different community education events in Massachusetts and internationally, and now here in Missouri. So one of the interesting methods of data collection that I tried to test out this year is actually engaging citizens themselves in research. So we employed something called Cannabis Citizen Science, where over these past events over the last year, I had booths like we do downstairs and raised awareness and asked if citizens, patients, or consumers would be interested in helping raise the awareness with their healthcare providers or in their local communities. And so these yard signs that I talked about over the last year, I took these yard signs and I took other flyers and pamphlets and tried to recruit volunteers in the community to be the change in the community. So you can see I've got yard signs in my my pop-up table down there, and this is one of Kelly, one of the leading cannabis citizen scientists. As soon as she signed up, she went and called as many healthcare providers and systems that she knew, and would go around to hospitals and bring flyers to raise awareness. The other innovative outreach data collection approach that we employed was a partnership with a cannabis transport company. They're a minority-owned cannabis transport company in Massachusetts, and they work with 90% of the industry. So I made an agreement with them they donated their time to deliver study packets to around Massachusetts. So earlier this year, in March, gave them 110 study packets asking them to deliver these to cannabis retail outlets, which they have, So all of these cannabis outlets on the map here have been distributed a study packet and asked for them to put it in display in their dispensaries and also an outreach to their local community health centers or their hospitals around the dispensaries to raise awareness and to ask healthcare providers to take the survey. So, interestingly, so this is an anonymous survey of any kind of healthcare provider. So you could be a nurse, a doctor, a pharmacist, a social worker, and could be anywhere in the United States, but we had this targeted data collection specifically in Massachusetts, but again, we had a national campaign around this. And these are some of the preliminary findings. Interestingly, respondents in California were our most popular, followed by Massachusetts. And nurses are the most common professional that was responded to the survey, followed by physicians and then nurse practitioners. Majority of our respondents are women, and we have about 10% of our sample, which is African American, and about 80% that is responding as white. In the sample of healthcare providers, 20% reported that they work for the Veterans Affairs, which is really good because it's a very different healthcare system. And the majority of our respondents are actually below the age of 40 years, around 50% are younger, and about 70% make $100,000 or less. 13% of the healthcare workers themselves reported being veterans, and 66% of them are actually working full-time. When asked what type of practice do you work in, the 18% reported working primarily at a private practice, followed by a government hospital, and then followed by a health center. The majority, or 28% of the sample, work in primarily urban populations, and it's about 17% in high income, 19% in low income or in middle income settings. Now this slide has the most interesting data point that was the most surprising to me at this study, and that is that 42% of these healthcare providers reported that they themselves currently consume cannabis. Yeah, right? When I started this study, Dr. Peter Grinspoon is a colleague and a co-investigator on this study, and he asked me, Marion, you are doing a healthcare provider study when you're in the middle of COVID, healthcare providers are really stressed, and you're asking them to spend 12 minutes of their life to fill out an anonymous survey. He said, these healthcare providers, they need, they could be potentially burnt out themselves. And so as I was running the study, that had that in the back of my head, and now to see that 42% of the sample actually currently report using cannabis is one, exciting, and two, begs us to really continue to think about access for our healthcare providers and also around rules and regulations at the facilities. 84% of the sample has actually already visited a medical cannabis dispensary, and majority of those that have reported that they consume cannabis, that they've had positive or very positive experiences with it. So just a summary of the study profile. We have the top respondents are nurses, women. We have colleagues that work at the Veterans Affairs. 53% is a younger population of respondents. 42% are currently consuming cannabis, and again, 84% have actually visited a dispensary. So we asked about your cannabis background and your beliefs. Now, also trying to understand, are these clinicians that have reported, are they currently registered to recommend medical cannabis by a state agency? And 54% of our sample are licensed recommenders of medical cannabis. And of those that are not, we asked, do you have plans to become registered? And 40% have plans to become registered. When we asked, what are some barriers or facilitators for you registering as a healthcare provider to recommend medical cannabis at the state level, 26% said they had no barriers, they want to be certified. 23% reported that the state government body doesn't recognize their profession to be certified. And I think this is really important. I think nurses and nurse practitioners are often at the patient level. And so really thinking about how we can work in that area, or also with social workers or those that work in recovery. The other, one of the other barriers that were reported was, the healthcare provider facility or organization actually was preventing the provider from getting certified. Some providers reported their workplace has a don't ask, don't tell policy. And then 8% reported that my private practice and insurance coverage actually prevent them from becoming medical cannabis recommenders. But when asked, what role do you think medical cannabis has in care overall, 37% reported that they believe medical cannabis has a role in first-line treatment for chronic pain and other conditions. And that's, thank you. I mean, that's pretty impressive. And followed by, the first-line treatment, 30% reported that they believe that medical cannabis has some role in the treatment of specific health conditions. 13% said medical cannabis could have a role if first-line treatments fail, and then 12% reported that they needed more scientific evidence to make a firm decision. Now, we asked about formal education around medical cannabis. 60% reported that they had some formal education around medical cannabis, and of those, 77% reported that they received CME credits as part of that formal education. And then 62% reported having a workplace policy related to medical cannabis. This slide is also one of my other sort of interesting slides of some of the findings that came out. The yellow and the orange bars are strongly agree and somewhat agree with these statements, and the darker bars are somewhat disagree or strongly disagree. So the majority of our sample believe that medical cannabis is effective, and also in the second bullet, believe that medical cannabis can be a beneficial tool to address the opioid epidemic. But you can see on the third bullet, less so people are reporting, or healthcare providers are reporting that they disagree with the statement that cannabis is a gateway drug to other illicit drugs, and that inhaled cannabis has the same risk as tobacco and other combustible products. In this sample, we asked also around, around the providers who agree, one, that medical cannabis is a legitimate therapy, and we can see over 75% agree with that. They also agree that medical providers should be offering medical cannabis in their regular practices to manage medical conditions. And providers are somewhat in the middle about the process for themselves to get certified in the medical cannabis program and whether or not certifying patients is difficult to navigate, and that difficulty actually prevents them from certifying. So regulatory barriers are still there. This sample, obviously we know, is highly familiar with cannabis. They themselves have consumed cannabis, and they reported in this sample that the majority of respondents also ask their patients regularly about their cannabis use and report that their patients feel comfortable talking to them about their cannabis use. But when we ask the healthcare providers, do you think your average patient is knowledgeable about medical cannabis, they're somewhat in the middle about that. We then asked on specific conditions, and as Marilyn said, these slides will be available, so I'll pass through them fairly quickly because there's a lot of conditions and a lot of questions that we asked. But in each of these specific health conditions, we asked, whether or not cannabinoids would be helpful for the treatment of these conditions. And by far, cancer pain is a winner in terms of a no-brainer for these healthcare providers that cannabinoids would be helpful. Seizures was also very high up there, and spasms. These are additional health conditions where we can see, healthcare providers are more comfortable around chronic pain and around post-traumatic stress disorder and terminal illness. and migraines, and less comfortable or understanding of the role of cannabinoids in treatment around sleep apnea, autism, and nausea. In terms of these health conditions, Parkinson's, the leading ALS, where healthcare providers believe cannabinoids can play a role. Additionally, with Alzheimer's, but less so with schizophrenia. And with Do Right, there's a need to really understand literature around that. Not only did we ask around medical cannabis and its impact on specific conditions, but also asked, to what degree medical cannabis can improve the following for patients. And physical functioning, enjoyment of life, mood, social engagement, sense of hope. Healthcare providers all felt like cannabis can improve a patient's life quite a bit or a great deal. So in summary, we have 354 healthcare providers. Majority have received some formal training. About half are actually registered by the state to recommend cannabis. And around 40% believe cannabis can be a first-line treatment, and 70% agree that cannabis can be used to address the opioid epidemic. And these were the top conditions, the most common conditions where clinicians felt cannabis could play a great role. So we asked also, medical cannabis is not for everybody. It does come with some risks, and we asked to what extent do we think that cannabis increased the risks for certain conditions. And you can see here, it's kind of a small font on the left. The top is psychotic symptoms, followed by depression, memory problems, respiratory problems, and motor vehicle accidents, with the largest concerns being related to psychotic symptoms and motor vehicle accidents. Here also, in terms of risk profile, the columns on the left, if it's too hard to read, is low birth weight, drug overdose, stroke, diabetes, heart attack, and cancer. And healthcare providers were most concerned that cannabis would increase the risk for drug overdose. Yeah. In terms of concern around possible diversions or rolling out of medical cannabis, healthcare providers expressed concern around driving, most concern around driving under the influence of medical cannabis, the lack of FDA approval of cannabis, and then followed by the link between medical cannabis and psychiatric illness, risk of drug-drug interactions, and then lastly, the possibility of diversion. These are also lists of concerns that healthcare providers had about medical cannabis, and the top concern here for healthcare providers was the potential for losing their medical license or legal repercussions of becoming a medical licensed practitioner. Stigma related to healthcare providers supporting cannabis as a medicine at the home and workplace was an issue. And then also healthcare providers were really concerned about patients being able to afford a legal supply of medical cannabis on a consistent basis. So in terms of, we asked healthcare providers, how do they actually, now we asked what you know, what your beliefs are around cannabis, then we asked, how do you want to learn about cannabis in the future, and what are the topics that you feel most comfortable about, and what you would like to learn about. And these, I'm grateful that the slides will be available because my time is running out, and there's a lot of detailed knowledge points in here. And I want to pause and give gratitude to, again, the co-investigators that I worked with on this study that helped come up with these questions and these knowledge points. And hopefully this data can help continue to drive the dialogue forward. And the respondents in our sample said they most preferred to learn about cannabis via lectures, and then followed by scientific journals, and then followed by news articles, a national curriculum, and then lastly, from a cannabis industry or a pharmaceutical rep. The next few slides are really about the level of knowledge that the healthcare providers reported feeling comfortable around these statements. Again, the yellow and the orange to the left is reporting completely confident or fairly confident. And the darker slides are not confident at all, or darker parts of the graph are not confident at all or slightly confident. And so providers on this slide among these knowledge points felt most comfortable about how to evaluate for drug-cannabis interactions. They felt comfortable knowing how to retrieve drug information for the use of cannabis for medical purposes and to evaluate for disease-cannabis interactions. Providers felt very comfortable and confident knowing how to talk to their patient about cannabis dosage forms that are available and how to talk to a patient about the medical uses of cannabis. In terms of the effects of receptors and the physiology of the endocannabinoid system, we have about half that feel very knowledgeable and half that are somewhat knowledgeable or need more information about it. In terms of the mechanisms of action and the pharmacology of cannabinoids and the receptors, the differences between endocannabinoids, synthetic cannabinoids, and phytocannabinoids, and the mechanisms of action. Again, in our sample, about half felt very knowledgeable about it and half felt somewhat knowledgeable or not knowledgeable at all. In terms of, and these are a lot of the deep dive things that the presenters presented about, so each one of these topics could be its own presentation in itself, but here the providers felt most knowledgeable and extra knowledgeable about the mechanism of action of THC and of CBD and felt comfortable around the differences between endocannabinoids, synthetic cannabinoids, and phytocannabinoids, but were less comfortable and confident about the endocannabinoid receptor activation and the physiology and more of those deeper concepts. These topics were related to how cannabis is metabolized in the body, and providers felt more confident around the effects of issues around labeling and accuracy of the ingredients, which I believe is really important. And they also felt very comfortable around, again, how cannabis products are metabolized. In terms of, this will be the last knowledge slide, and in terms of the differences between distillates and whole plant cannabis and CBD products, our sample felt pretty knowledgeable about that. Also how to dose patients with health conditions with CBD or medical cannabis, and also felt very comfortable about the potential role of terpenes in enhancing cannabis-derived products. So some very quick key takeaways. Over half of our sample is very knowledgeable or knowledgeable about key cannabis competencies. They are heavily, as I said, about 42% actually consume cannabis themselves and have been in the dispensary. So it's a knowledgeable population. They were less likely to report knowing the mechanisms of action and unsure really about the FDA and non-FDA approvals. And rounding out this presentation, we asked what you would like to learn and how you would like to learn it. And here, majority, although they said they've already received education, 66% of our samples said they still need further education about medical cannabis. 62% needed more about the endocannabinoid system. 63% wanted to know more about where they could find medical cannabis in the scientific literature. 55% were curious about where to find legitimate medical cannabis education courses for continuing education credit, so I'll keep spreading the word of patients at a time. And 60% reported they prefer to learn about medical cannabis through an online CME course, but they also prefer to learn in person as well. This was a select all. And in which disease areas we asked, would you like to learn more about? And you could see it's kind of across the board, but the most common were depression, chronic pain, and then anxiety, and then 70% were interested in learning about the reduction of prescription and over-the-counter medications related to cannabis. Finally, healthcare providers were asked if they agreed or strongly agreed or disagreed, and this graph shows the respondents that strongly agreed or agreed with the following statements. Medical cannabis should be part of the required curriculum in the next 5 years. 72% agreed. 74% agreed education on how to discuss and counsel the risks and benefits of cannabis use should be included in the curriculum, an academic curriculum, in the next 5 years. 69% agreed education on the pharmacology of cannabinoids and cannabis use should be included in the curriculum. And that finally 72% agreed students in my profession should receive education on the programs and the laws related to medical cannabis programs. So some next steps, we're going to continue data collection until August 1st with our partnership with Eagle Eyes Transport, and continue to get the study packets out there and continue to outreach for healthcare providers to take the survey. And then we will be preparing a final peer review publication for submission to a journal for peer review. So that's it. Thank you very much for listening and having me here.
All right, as we said, we want to get more clinical. And thank you, Dr. McNabb. That was, again, considering that was, I was even surprised, considering that was a population of healthcare providers who had a little bit of knowledge that they didn't, that it wasn't even higher for wanting it included in curriculums. It's like, boy, all these new people, new clinicians coming out there, we want them well educated if they're going to take care of us. So now we're going to hear from some local care providers, get their perspective from, they're all from Missouri, so we'll get that. And Dr. Deb Malka is going to lead the panel here.
Hello, welcome back. So in the transmutation or transmigration of cannabis competency, challenges, successes in the practice of cannabis medicine, we have a large range from new states. There are certain challenges with that when the information's new, and there's a lot to be learned from other states that have done this already. So today in this panel we're going to focus on some of the challenges that are experienced in a newly registered state such as Missouri. And we have Dr. Paul Callicoat, who will speak first. He's a retired cardiologist, and he's involved in education. Yeah. Are we good? Oh, okay. Everybody's looking at me. What am I doing wrong? Then we have Lisa Roark, MD, who's a family practice physician that actually integrates cannabis information into her practice. That's really hard to do. Yay. And then we have April Hatch, who's a nurse who is part of the cannabis care team that provides cannabis education to patients. And they'll each speak for about 15 minutes. And then I'm just going to give a few minutes of perspective of trials and tribulations of an experienced cannabis clinician and what still needs to be considered at that point, 20 years later. So with that, we'll begin with Dr. Callicoat. Please do. What do I know?
Is that okay, Dr. Callicoat? Can I introduce you? I think we have some disclosures or conflicts of interest. I get paid to talk about cannabis. I think we all probably get paid to talk about cannabis because that's what we love doing. And it has become our jobs, but I wanted to introduce these two doctors, Dr. Paul Callicoat and Dr. Lisa Roark. The reason why we have medical cannabis in Missouri is because of these two doctors. You have no idea what a struggle it's been over the last how many years. And it's because these two people were going everywhere, all over the state, telling everyone that cannabis is medicine. Look at these people. They convinced all Missouri constituents, legislators, that we need to have this in our state. So thank you for that so much. And then, how many doctors do we have in the room? Okay, all right. So we're trying to get medical cannabis legal in the state of Kansas, which is just a mile right over there. There's no legal medical marijuana over there. And we need all of the doctors here who know about cannabis to come talk to the legislators in Kansas. Will you guys do that? Please, Zoom, write a letter. Please help us get cannabis in Kansas. There are so many Kansas patients who need access to medical marijuana. There's 3 ladies right there. Talk to them. And that's all I want to say. And then Dr. Callicoat of Sarcoxy Nursery, who's the most amazing wife, Wendy Callicoat. Yeah. And their son, Jonathan Callicoat.
So this is why I didn't want to go first. So thanks for inviting me here. I'm not really sure why I'm here. I hope I have a lot to contribute. I hope I have a perspective for the practicing physicians, the nurses, any healthcare providers out there. I hope I have a perspective and I can help you with your quest to use marijuana as a medicine for your patients. And yes, I said marijuana. I apologize. I'm old school. I don't mean any disparities by it. So I really haven't done this in the past. I have spoken quite a bit about marijuana, trying to get Amendment 2 passed. I wasn't interested in the politics of marijuana until my son got me involved. Back in the day, I don't know, 2015, 2016, whenever it was. So at that point, I said, yeah, that really makes sense to me. And the reason it made sense is because I was raised in eastern North Carolina, and in eastern North Carolina, we grew a lot of tobacco. And so along with the tobacco, marijuana grew. I was raised in a military family. My father was in the Marine Corps, so we traveled around quite a bit, but I was always on a base. In eastern North Carolina, during the Vietnam War, I was in high school. And a lot of my friends and associates and people and young Marines that would come back, as you all know, that was an easy way back then for drugs to get into the United States, was on all of these carriers that were bringing all of the military personnel back to the country. So drugs were widely acceptable or available. I shouldn't say acceptable. They were widely available back when I was in high school. So at that period in my life, in my very early days, I used marijuana, organic materials such as marijuana, psilocybin, peyote. Those medications were available back then. At that point, I had no idea I was going to be a physician. I had no idea what I was going to do. Went to school, got through, actually I started school, believe this or not, I started school here in Kansas City. I went to Penn Valley Community College. My first courses were actually in the old campus over on Westport. Probably nobody even knew that Penn Valley Community College was on Westport. But way back in the day it was. But anyway, I started school, got through school, decided to become a physician. when I got to laying hands on people, I decided, okay, you really, you can't do that anymore. So there was about a 25 to 30 year period of where I used no alcohol or minimal beers, no marijuana, no other anything. I had a very active practice. I was an interventional cardiologist. Most of my career was spent down in Oklahoma. I took care of a lot of Native Americans. Native Americans have a difficult time accessing medical care, especially from cost. So I learned how to be very streamlined in my care for patients. I sought out medications in my practice that worked. What actually causes a clinical event in my patient that I can say is a positive event? And we only had a few drugs, and we still only have a few drugs in cardiology. We have beta blockers, we have statin drugs, and a few other, but for the most part, we don't really have a wide array of medications that work in cardiology. So my approach to it is look at the literature, see what works, see what doesn't work, and then try to find the cheapest method of administration for that drug. And that's the way I approached medication, and that's the way I approached my whole practice. And there's a few things that I learned from that I think that translate over into practicing with marijuana. One of the important things is that observational studies are not double-blinded research studies. So I think you have to be very careful in the literature what you look at and what you see and what you read, because most of the stuff that we do read now is an observational study, and those are very handy. But I mean, you can go back and it doesn't really mean anything. Everybody can observe that I've got pink socks on today. What inference are you going to make from that? I mean, I don't know. Talking about that relates to the gateway drug. The reason that the marijuana is supposed to be a gateway drug is because people that use opioids and harder drugs have used marijuana. So what? They also used caffeine. Is that a gateway drug? Well, I'm talking about caffeine. Another important thing that I think needs to be pointed out is this addiction thing. We talking about addiction in marijuana. I don't see it like that. Marijuana is not alcohol. You don't have the same physical withdrawal. What I get when I quit using marijuana is a headache. To be honest with you, I get worse side effects from not using caffeine in the morning than not using marijuana. So how is that an addiction? It's not. It's a dependence. I'm sorry. So there's a dependency on a marijuana. There's a dependency on caffeine. It's not an addiction. It's two completely different things. This addictive marijuana is just. And I'll take you back to the gateway thing. I had a friend that was a senator in Oklahoma. He was a physician as well, and he was terribly against the Oklahoma marijuana. And I asked him why, and he says, well, it's a gateway drug. And I said, why do you think that? And he says, well, I work in these prisons, and every one of them I asked, it's in there for drugs. I asked them what's their first drug, and they say marijuana. And so therefore, it's a gateway drug. It's not. The other thing I want to point out that I think is important is the drug itself. I'm a whole flower kind of guy. All right? I just am. That's what works. I think that's what the literature supports. There are some seizures. There are some illnesses that respond well to an isolate of some sort. But I think overall, what's our job as a physician? Our job as a physician is to make people feel better and do no harm. How do I make you feel better? Well, with marijuana, I get you to use marijuana. But in my mind, it's a whole flower type of thing. you know, I'm probably going to take some booze for saying this, but inhalation for me is the way to go. I hate edibles. I just hate it. So, you know, I mean, from a physician standpoint, a heart and lung kind of guy, I mean, again, I was an interventional cardiologist. I was the guy that was on the inside of the arteries. From that standpoint, telling somebody to use a combustible product and put it in your lungs is just silly. However, I go back to my other statement. What do I look at? I look at the data. I look at the data. And what does the data say? We got no correlation with anything except possibly increased bronchitis. That's it. Cancer, none. Read any of the studies. Well, we haven't determined the causation yet. That's because it's probably not there. It's just probably not there. So again, I'm a whole flower kind of guy. You know, as far as dosing goes, dosing with flower is difficult. I think marijuana gets a bad rap as far as medication goes because the dosing is too high when patients initially use the drug, use the medication. I think a much lower THC content these days is the way to go. I think a high CBD, a one-to-one is, I think, mostly preferable. Dosing, again, is difficult, but I think you can do it. I'm interested to hear from Lisa when she comes up about how many patients actually come back and say, okay, I need you to fine-tune my drug. I need you to help me with my dosing. I bet there's not a lot. I mean, I don't know. I haven't asked the question, but I bet there's not a lot. So I was talking yesterday or whatever, you know, what is our goal? Our goal is to make patients feel better and do no harm. How can I make patients feel better? What does marijuana work for? Well, it works for inflammation. Anything that is tied to inflammation, gastric, chronic pain, whatever, it's certainly worth a try. I broke 3 ribs, fell off a horse. I was bird hunting, quail hunting down in Georgia, fell off a horse, broke 3 ribs. I had already used opioids for a back problem and just refused to do that anymore. Non-steroidals, marijuana got me through 3 cracked ribs quicker than what people said you usually take to heal from 3 cracked ribs. So as far as the opioid epidemic, as far as patients in chronic pain, there is absolutely no reason in the world to be prescribing an opioid right now. The data is out there that THC is a better pain reliever. There was a study from the VA hospital that found opioids non-superior to THC in relieving chronic pain. NIH published a paper saying that THC has more anti-inflammatory properties than aspirin. So, I mean, you know, you got a chronic pain, you got back pain, you got whatever, try low-dose marijuana. Well, there's a lot of things. I'm probably over my 15 minutes. I don't know. But I got a lot more to say. Just ask me.
First, let me just say my answer is D, all of the above. My favorite method of consumption. D, all of the above. So, my name is Dr. Lisa Roark. I am an MD physician, but really I'm a DO stuck in an MD's body. It just happened that way. I have a bit of a story, and I will try not to be too wordy on it. In 2007, I graduated from UMKC and became a family medicine doctor. At that point in time, I had zero knowledge of CBD, cannabis, really most holistic medicines. None of that was covered in my medical school, zero. The only coverage I had was, this is a drug, Here's what you do to try to prevent your patients from using the drug. And then if they use that drug, here's what we're going to do to try to stop it. That was literally the education I got, okay? Went to residency, still no education. I mean, we worked with a pharmacist every single day. A pharmacist rounded with us, and there was no education for cannabis, zero. So go forward a few years, I went into the typical medical health care system. It was not right for me. I'm one of the unique people in here that doesn't fit inside of all of those boxes. So after my 5-year contract, I left the typical health system and opened a direct primary care clinic in Cassville. So a membership-based, no insurance, no government money. I opted out of all of it so that I could do what I felt was right with my patients. I also lost my health insurance, my, everything that you work at a hospital system for, my health insurance, my malpractice insurance, my, someday I would like to retirement. So I lost those things as well, and luckily had a husband standing beside me that said, when I said, what if I fail? I mean, this is how our family lives. He stayed home and raised our babies. What if I fail? And he said, so you'll go to work for Cox or Mercy or whoever. You didn't fail, you tried. So we did it, and we lived very inexpensively. We sold everything that we could sell so that we could stay out of debt. He remodeled the clinic himself with me and our kids. We have pictures of little toddlers learning how to tear down walls and all kinds of good stuff. So that was the beginning. So I became me as a doctor. Go forward a few years, and I had a patient whose child had seizure disorder. He had gone through multiple medications, was failing it miserably, and she said, the neurologist won't even talk to me about it, but I want to try CBD. Will you help me? And I said, I don't know, because I don't know anything about CBD, but I will promise to learn, and then I will tell you what I learn. And that was just the beginning. And that was right before the ballot measures and yada, yada, yada. So I ended up speaking at town hall meetings. I'm a guest lecturer with the St. Louis University Cannabis Program. I'm just an educator. Thank God cannabis came to my life, because in 2019, I lost vision in my left eye. Go forward a little bit, I have multiple sclerosis. I have resistant multiple sclerosis that did not react to the medications. It didn't react to the steroids. I was on my way to not being able to walk and losing my vision, and thank God for cannabis, because then trigeminal neuralgia started. And anyone who's not familiar with it, they call it the suicide disease. It's where the trigeminal nerve, so your facial nerve, is affected by the MS, and it fires all the time. So I spent 2 years where I couldn't smile. I couldn't drink cold, I couldn't drink hot, and I treated it with cannabis. As a physician, here is how scary that is, okay? My medical license has been investigated since day one of doing certifications for patients. Okay, this is the real stuff I want you to know. I don't have malpractice insurance that covers any patient that I talk to cannabis about. And I've chosen to continue to do my practice, because I'm not just cannabis medicine. I mean, I do, like I said, I'm direct primary care. I see kids, I see adults, I see elderly people. I'm in clinic all day, every day. And I don't utilize cannabis when I'm at work. I can't prove that. Okay, just the fact that I admitted on this stage that I use cannabis, probably I'll be dealing with the licensing board on that as well. But these are things you need to know about. So you can't, as a physician, as a nurse, if someone wants to sue you, you're not covered by your malpractice. And they're very clear that you aren't. If the licensing board wishes to investigate, they can. And here, this has been my response. I've done nothing wrong. I follow the law to the T. I mean, to the T. And when they can prove that I've done something wrong, then they may look at my charts. And until then, they won't. So I've just said, no, thank you. Subpoena me. So that's been almost 3 years. Almost 3 years. And so far, I haven't even spoken to them. I just let my attorney do it. Now, as far as caring for patients, yes, I do a lot of certifications in the state. I do a lot of pediatric certifications because there are very few doctors in Missouri who feel comfortable with that. And don't tell anybody, but I do all the pediatric ones for free because I just think it's the right thing to do. It's just the right thing to do. So yes, I do the certification, but the bigger part is not the certification, it's counseling the patient. It's counseling that mama. And that's truly what we're missing. And the reason why is we're all so afraid of what the licensing board's going to do. What are they going to do if I write down how to use a patient's cannabis? They're going to call it a prescription. I can't text my patients and use the word cannabis in the text because it gets blocked by my EMR. I have to say, this is the website. I can't even text the Missouri Medical Marijuana website patient education information. I can't text it because it blocks, because it has marijuana in the name. So Missouri's a very conservative state. I am very, very happy that this law has passed, but we have a huge lack of physicians, nurses, really the medical community supporting it. It's almost like the medical community just kept going as if it never happened. And what's happening is these patients are getting certified and they're trying to do what we tell them to do. We tell them, tell your doctor you're using cannabis so there's no interaction so they can help counsel you. You know what happens when they tell their doctor that? You're a drug user. You're fired. Dr. Roark, I can't even wean off of my opiates. They just told me they won't prescribe them ever again because I was honest with them. And that is what's happening. Now, as far as the opiates go, I have a licensing waiver and I do provide Suboxone therapy for my patients with opiate addiction. So I am very supportive of not having people on opiates, obviously, but utilizing cannabis as a reason to just fire them and leave them high and dry is certainly not what we promised to do when we took our Hippocratic oath. So fast forward to today, I work less, I spend more time with my family. I did a very radical treatment in Mexico for my MS, and part of that was chemotherapy, and this is how my hair came back. So if you see me and you go, oh, you look so much different, yeah, because you got a little wild hair going on. But thank God my treatment stopped my MS, and through cannabis, yoga, healthy lifestyle, and 0 MS medications, I walked up on this stage with high heels on for the first time in 3 years. 3 years. That's all I got.
Aren't they both amazing? I had some notes in my phone, but someone's using my phone right now. So what I want to do is I want to talk about the patient experience in Missouri, or the patient experience in a new state. But first, let me give you a little bit of background of what I do. So in 2015, my son suffered a TBI. Fast forward a year, we got him off all of his prescriptions, and he was on medical cannabis, but it was illegal. I was afraid I was going to lose my nursing license. I was afraid I was going to lose my children, that someone was going to come rip my children out of my home because I was giving my 15-year-old son medical cannabis. I was really, really scared, but I saw what it did for him, and I wanted to tell other people that how to use it too. And I worked with a lot of hospice patients and palliative care patients and patients who just wanted to feel good. And I told them all about cannabis, but I was, again, really scared. So after these two people drove around all over the state and a lot of other people in this room and convinced everyone that medical cannabis should be here, and it passed, I came out of the closet. I actually did grow up in a pretty cannabis-friendly home, but I had no idea that it was actually medicine. My parents always used to use cannabis. It was just a part of their life. We had gardens, we did things outside, we loved people, and there was always cannabis. But in 5th grade, and I'll share my DARE story. I wasn't planning on it, but I will. It's a good story. I know you've all heard it before. I remember in 5th grade, I was sitting in the gym on the floor, and this police officer in a uniform was standing up there, and he had this poster, and he had all this paraphernalia taped to the poster. And I remember looking at it, and it was like, "These things are going to kill you." And there was a dugout and pipes and all these things we had on our coffee table and everywhere. And I was like, and I knew exactly where they all were. And I went home, and I remember the dugout. I took it, my dad's dugout, probably his favorite one, and I threw it in a sewer or a ditch or somewhere, and my parents were pissed. They were not happy. But that's what I thought. I thought I was saving my parents' life by throwing away the dugout. I thought that they were going to die if they didn't stop using cannabis. So, I mean, eventually I became a teenager and liked to have fun and experiment and used a lot of cannabis. But when I became a nurse, I knew that I could not use cannabis. And if I did, I needed to make sure I knew how I was going to get a clean UA. So you just never know when you're going to have to take a drug test as a nurse. I mean, honestly, someone else could screw up, and you're the one who has to take a drug test. So I paid a lot for nursing school. I got a master's degree in nursing. No one ever told me about the endocannabinoid system. I graduated in 2005 from nursing school, and no one had ever mentioned the endocannabinoid system or said anything about cannabis. Nothing. And I want a refund. I want my money back. We should all ask for our money back. We all know we're all here talking about the endocannabinoid system and beyond, but it is the most important system in our body. It is what keeps us all in balance, and this world is completely out of balance. So we need to get the people back in balance, so we can get the world back in balance. So I'm going to move around a lot, and I apologize, but it was legal in Missouri. I'll go back to that. And I said, I want to do this. I want to help people. And I read about this guy. His name is Dr. Dustin Sulak. I'm like, wow, he really knows what he's talking about. I want to go listen to him. I want to go learn from him. And he just really put everything into perspective for me. He told me, and this is a plant. This is not scary. This is not something we need to be really worried about. This is medicine. We can help people with this. It doesn't have to be like all the other medications that you deal with as a nurse. And I was really happy about that he was able to show me that we should see it that way, because the medical system does not see it that way. They see it as dangerous, unsafe, addictive, not studied. Oh, there's not enough research. I've been saying this for the last 6 months. If we could just get everyone in a room and I could just hear one less person say there's not enough research, I know I've done my job. I'm so sick of hearing there's not enough research. Do we really need that much research on a plant? I don't know. So I do want to share a couple patient stories, because I started working with patients individually, because I love helping people. It's why I became a nurse. I love taking care of people. I don't know if you guys noticed, but I get to talk to a lot of patients in Missouri, and usually it's when they need something, and I will help them get what they need. So most recently, there is a a patient. His mother calls, and English is not her first language, and her son is 19 years old, and he's severely autistic, and he's hurting her. He's 260 pounds. He's 6'2". She's a very small, beautiful, this amazing, beautiful woman, and she's just very petite. And I mean, he's really hurting her. And she doesn't know what to do. She has no idea what to do, but she heard that medical cannabis could probably help him from some friend, and she got my number. And so after, several phone conversations and with my mom, Heidi, who takes all those initial calls, we figure out what she needs and how we're going to help her. So she just needs to get a medical card for her son so he can have access to this plant, right? It sounds really super easy. You just need a medical card to see the doctor, apply to the state, pay the fee. It sounds so easy, but it's not for so many people. You have, honestly, no idea. To get a photo of this child in front of a white wall with him not smiling and no glasses is not possible with this child. It just can't happen. He is so just a beautiful human being, but doesn't want his picture taken. Why do we have to do that? She has the physician appointment with me there, and we get the doctor to write the letter, and we talk about the next step. The next step is all the paperwork. You have to prove that you live in Missouri, which can actually be a real problem for people who don't have their name on a utility, or maybe they're living with friends or family. You have to prove guardianship because he's an adult. That's not really easy when you don't have the paperwork, you don't know where to get it, or you don't know how to get it, or you can't afford a lawyer to do it for you. It's really, really challenging to get some people medical cards, and I don't understand why we have to make it so hard to get people access to a plant. Another patient, this is one my son told me about. So my son is my story. He's my why. He's 21. He's amazing. I wish he could be here so you could all meet him. But he has a lot of friends who need medical cards, and I help his friends get medical cards. These kids just want to use cannabis. They don't want to go out and get drunk like all the other 21-year-olds. They want, right? Medical cards cost money, and medical cards require steps and a process. And it's not easy. It's just, it should be so much easier, but I send them a link, I tell them what to do, and I think it was just a couple of nights ago, he said, "Mom, I have a friend who needs a medical card." Okay, send me their name, text me. He's like, "No, Mom, this guy really needs a medical card, Mom. You need to take care of this guy." Okay, what do I need to do? And this 45-year-old man, I'm sorry, is living in the state of Missouri, has a job, is a functional person in society, honestly hasn't gotten a medical card, doesn't know how to get a medical card. A lot of people in Missouri don't know how to get medical cards. A lot of people in this neighborhood around us don't know how to get medical cards. He's gotten arrested 4 times in the last 2 years for cannabis. And it could have been saved with a $250 to free medical card. It could have been so simple, but people just don't know. So we need to work with organizations like the Cannabis Project, which is downstairs. They've gotten, I don't know if they're in here. How many people have you gotten out? So they've gotten 6 people out of prison in Cannabis in the state of Missouri for cannabis convictions. That's really powerful when we have an industry here in Missouri, and I hate the word industry. I really, really hate that. But we have an industry here in Missouri where we're going to fun parties and we're having expos and we're, you know, people I think are making money off cannabis, and we still have people in prison. I just don't get it. It doesn't seem right to me. So please see the importance of organizations like that. And Cruel Consequences is downstairs. Tamara Netzel, she's actually back there in the corner. She does a really good job at sharing patient stories. And I have a prop. Okay, yes. Yeah, I have a prop. So this is the casualties of the drug war poster that's on silent auction downstairs that Bryan Krumm donated. So that is a 20-year-old poster. It says casualties of the drug war. I mean, seriously, we have not figured this out. That's 20 years old, right? We should not have any more casualties of the drug war. This plant should be free and accessible to everyone all over the country, and organizations like Patients at a Time help make that happen. We need nurses, doctors, pharmacists, physical therapists, occupational therapists, aides, everyone who is patient touching to know how cannabis works. We need everyone in the hospitals, the clinics, everywhere, and any opportunity they get to tell a patient about medicine, which is cannabis, they need to tell them. We need all of the nurses, doctors, pharmacists in here to take this information back and share it with your colleagues and have them come to Patients at a Time next year so they can learn about it. It's truly an honor to get up here and stand and speak. I don't mind the speaking. I'm a little tired this morning, but with these two people in front of all of you, there's so many people here in this room from the Missouri cannabis community who made medical marijuana happen. I just want to say thank you to all of you, because if it wasn't for the community and all of these people working together and all the cannabis nurses, I mean, seriously, cannabis nurses, there's probably 40 of us in the room right now. I mean, we have a lot of power. We can do a lot. Nurses can. And I've been talking to a lot of people about the power that nurses have, and I think people are finally starting to listen, because that poster is 20 years old. That wasn't working. We need the nurses to do it. Nurses know how to talk to patients. Nurses know how to educate patients. Nurses know how to hold the hands of patients and listen to them and support them and love them. And nurses know about holistic medicine. I mean, that's what we do. We know holistic medicine. We know how to help people. We know how to make them get better. We need more nurses doing that. And actually, can I do something right now? Can I? Can I have all the nurses in the room stand up? All the nurses. And can we get a photo? Please, somebody take a picture. Wait, can I take it? Do you have a photo? Do you have a camera? Hold on, we're gonna take a picture. Hold on, keep standing. Keep standing. Okay, thank you. Okay. Oh, I don't know how this works. Dolores gave me her phone. I'm in trouble. All right. Yeah. Thank you, Greg, for taking a picture of all of the nurses in this room who are going to actually get patients access to a plant. It's us. It's really, really on us. It's our responsibility. We have to do this. We can't rely on anyone else, okay? We have to do this. Okay. I don't know.
Since no one else is going to say it, I've actually seen April's name for the 6 months that we've been planning this conference, because I looked up the Missouri Cannabis Trade Organization and I saw important people listed, and I said, oh, she knows about this stuff. We need to get in touch with her. Turns out she'd already gotten in touch with us, but she's a great force behind making this whole meeting happen. So thank you. So I wasn't prepared to speak at this moment because we were potentially going to have a Q&A, but we actually have a session for Q&A with all the faculty at the end of today, so that's when you can share your questions with this group. We decided it might be useful to give another little extension of range of feedback about what it is to have a clinical cannabis practice, challenges that may or may not be down the road. So I'm going to address that a little bit. So I started working in cannabis as a recommending physician in California in 2006. And at that time, it was only 2 years since the Medical Board of California stopped suspending doctors' licenses for recommending cannabis. So cannabis had been approved for 8 years, and every doctor that they wanted to make an example of that was recommending cannabis, they put him on probation. As a matter of fact, I was a practice monitor for a colleague of mine who got put on probation for 5 years. He was a holistic psychiatrist. And he said, I need you to sign my papers. And I said, I'm not a psychiatrist. It doesn't matter. You just have to be a licensed MD. I said, okay, I'll sign your papers. You teach me holistic psychiatry. And we had a 5-year deal going on. And that was my, that's a true story. That was my introduction to what can happen to physicians. That was back in about 97. So while I knew that cannabis was out there, like most physicians in my community, I knew that I shouldn't touch it because the medical board was going to pull your license or put you on probation. That lasted until May of 2004. Then somewhere around 2005, my 18-year-old son went and got his medical cannabis card. And he came back from the cannabis clinic because, you know, most physicians, other than maybe cancer doctors, were much too scared to sign their name to a piece of paper. But by this time, there were specialty clinics. He came back from the clinic, says, Dr. So-and-so says hi. I said, oh, where'd you see her? He said, oh, she gave me my medical cannabis card. And that was the first that I heard that there were places that did that. And there began a policy in California of pot doc clinics. We were called pot docs. And it was not an uplifting term. It was a derogatory term. Because all you had to do was sign the paper. You weren't required to take any training. You didn't need to know anything. And unfortunately, that was the practice. You know, California, I could be wrong, but I believe that it got up to about 1 million medical cannabis patients before recreational became open, and then that number went way down, which is where I'm going with this. Anyway, most of the doctors didn't know anything, so there was a practice going on with these 1 million patients of getting a piece of paper that made it legal for them to enter a dispensary and use cannabis theoretically as a medicine, but in fact, probably 95% of these people had to find out how to use it as a medicine from the internet, like the doctors who wanted to learn because there was nowhere even to learn. As a matter of fact, I went to my first Patients Out of Time conference. I just missed the 2006 one, but I went in 2008, and that was the first place that I really could learn. I got to throw this out there. I actually tried to learn from what was written in journals. And there was a defunct journal, Journal of Cannabis Therapeutics, yay. Mary Lynn was part of that. A 2002 article that I couldn't find online, so I actually had to go down to the stacks of the medical library. And, you know, there were so few papers back in that day. Anyway, fast forward. So through the 2000s, we were dealing with mostly THC-rich cannabis that was available in dispensaries, so the practice was very different. You really had to talk to your patient about how to manage THC-rich cannabis. There weren't any alternatives. Then around 2010, 2012, CBD started showing up. More and more strains of CBD started becoming available, but dispensaries didn't want to carry them because the patients didn't want to buy them because it didn't get you high. And so we really had a very underground network for how to get our patients CBD-rich cannabis. And hemp, of course, was outlawed. So then came an interim time for about 5 years, I'd say, where we knew about the effects of CBD, but we didn't know how to help our patients get it. And we, some of us had like underground networks where we could tell, well, go to this provider or that provider, and they might have a few bottles or whatever. Then CBD started showing up in dispensaries, and there started to be an excellent array of all kinds of combinations. They started to be lab tested. I'm skipping over all the mistakes that we had with the ones that weren't lab tested, and the violent patients ended up becoming more violent because they got the wrong bottle of stuff. I mean, lab testing's really important. Anyway, there were many cottage industries in Santa Cruz, California, where I was practicing, that made beautiful, homegrown, full-spectrum extract, tinctures and edibles and, pesticide-free flowers and all this stuff. And we had a booming medicinal industry going in our community where you could specify any combination of cannabinoids. We even had THCA and CBDA. We almost even had THCV. I had a side source for that. So, I mean, this is like the apex of you can get the medicine you want, you can get it lab tested, you can get it having been lab tested, you can get it in multiple delivery forms. If I couldn't get what I wanted, I'd call up my friend, Connie McLaughlin-Miley, who was a cannabis pharmacist, and she formulated anything that I wanted for me, and she spoke with us yesterday. So this is the apex. This is the wonderful place you can get to where patients can actually come, you can tell them what medicine to get, you can tell them where to get it, and you can see really positive, good results. And everybody's happy. And then recreational got passed in California, about 2018. And this is the trajectory that I hope somehow we can reverse in our country as far as medical cannabis. Because these wonderful patients who did so well have been entrained, most patients, most of us, we're all patients, have been entrained to not go to a healthcare provider unless they have to, especially when it's not covered by their insurance, which visits with the cannabis physician were not. So all of these patients, not all, I would say over half the patients that I had no longer seeing the requirement to come back and get certified in order to enter a dispensary, stopped receiving benefit of professional guidance. I mean, really, if they spent $100 a year, they'd save $1,000 a year at the dispensary, because now they have turned to the dispensary agents, the bud tenders, for advice on what to get. Having forgotten the 10 years of visits and what kind of formula we came up with and what really works best for them, not everybody, but over half. And so I have lost the medical cannabis patients that we worked so hard to fine-tune their medicine. They're getting no feedback from their primary care doctors on any of what they're doing. I'll come back to that in a minute. They're actually getting harmed by hearing from dispensary agents about what to take, because those folks in general, even if it's still a medically oriented dispensary, are geared toward a population of wanting THC-rich products. We lost all of the cottage industry when it went recreational, all the small companies that were making so many of the excellent products because they couldn't afford the $300,000 that it cost for permits, nor even get one to stay in business. So what I want to say is is that if you have access to patients during this very short window before legalization, decriminalization takes over, make sure that you emphasize the ongoing need for professional guidance about how to use cannabis as a medicine, because the entire culture that we live in, from the dispensaries to the doctors to our history, has been entrained in cannabis as a recreational agent. I would dare say that even most people who think they're using cannabis as a medicine, if they haven't seen a doctor like me or Dr. Sulak or maybe 10 people in this country really who know the breadth and depth of how to use cannabis properly, how to get people off their other medications if they're using cannabis, that they're really not getting the full benefit of the medicine. So learn a lot and spread the word, and most of all, make sure the patients understand that you're not doing this for them to be legal, but you're doing it so that they can learn how to use this very effective medicine. So I think that's it. We're out of time.
So I was expecting an opportunity to be asked questions. I don't know if I'll be here this afternoon for questions, but I do want to make one final point here. And I agree with everything that was said up here. But again, I think from our standpoint, as far as a clinician goes, our job is to do the best we can for our patients. So if you're a healthcare provider and you see patients and you're not able to send them to a specialist, they can't afford the specialist, there's none available, I think it's incumbent upon you to know what marijuana works for. I agree, it's fascinating to know why it works and how it works. I don't think anybody here, well, I shouldn't say that, but who remembers what FA does? But I don't think your patients are really going to need to hear what FA. What you as a primary care physician or a nurse that's going to touch patients, you need to know that cannabis works in certain things, and you should advise your patients to try it. If you can't get them to a specialist, then so be it. I think a medical card is a great thing. I think coming back to your physician or your nurse and talking to them is a great thing. However, I also think advising your patients that there's an organic medication out there available to them in multiple forms is your responsibility. Now I'm done.
It is refreshing to see clinicians who give a about their patients. And I think that's it. What we've enjoyed with our conferences many times are clinicians leaving and being very upset that they didn't get this education in their school. Since the mid-1990s, we've known about the endocannabinoid system, and as April said, she wants her money back. In school, forgot to teach the basic thing that keeps us in balance. How can we not fit that into the curriculum? So that's a big call. And here in Missouri, again, yay, St. Louis University does incorporate that in their clinician. So we're going to take a 15-minute break. When we come back, we'll be talking about cannabis dosing. Dr. Sulak will be talking a bit about that. Write your questions down, folks. Anybody out there listening, watching virtually, put your questions in. We'll try to get to them at the end of the day.
We're going to do a group photo of all of the nurses in the room. If you could come stand up on stage. Does that work? All of the nurses up on stage. We need a photographer who wants to take a picture.
All right. We're back again. And again, now we're going to get clinical. So coming up next is Dr. Dustin Sulak. You all know him, osteopathic physician from Maine. Going to talk about cannabis dosing distilled.
Good morning, everyone. Glad to be back here. We had such a fabulous day yesterday. So over the next 45 minutes, my goal is to convey to you some of the basic principles of cannabis dosing without necessarily giving you the how-to for specific conditions, because cannabis really invites us into a different paradigm of individualized treatment, whereby if we know the basic principles of cannabis and the basics of what's going on with our patient, we can usually devise an individualized regimen that can maximize the upside of cannabis and minimize or completely eliminate the downsides. So we'll see if we can convey that all in the next 45 minutes. Just to begin my disclosure, you all saw that yesterday, so I don't think I need to repeat it. These are the topics that we'll be covering: the wide, safe, and effective dosing range, the nonlinear dose-response relationships, the therapeutic window of THC, using THC dominant versus mixed versus CBD dominant formulations. We'll cover some specifics for dosing for people that are new to cannabis, how to use cannabis without becoming impaired, what are some of the benefits of the psychoactive effects of cannabis. We'll talk a little bit about strategies for people that are already using cannabis but maybe need to shift into using it more medically, and then dose layering with different delivery methods. So when I see a patient, what's the goal? Why are they coming to me and why am I working with them? It's usually about function and quality of life. This is really what it comes down to. And I want you all to, when you're working with patients, stay oriented on some of these individually defined goals. When I see a patient, I usually ask them a question like, imagine 3 to 6 months from now, you're feeling much healthier. What does that look like? Will you paint that picture to me? And they pause. It's a tough question to answer. It takes some time. And then I usually hear some very specific things like, I'd like to be able to take my grandkids to the playground, or I want to get back to hunting, or whatever it is that's so meaningful to that individual. And I put that goal right into their treatment plan that I end up printing and giving to them, because it shows that I listen to them and it helps keep them oriented around that vision of health. And a lot of times that goal isn't, like if I ask that question, they say, well, I would have less anxiety. And I say, well, instead of less anxiety, what would you have more of? And then that gets the wheels turning. Well, maybe I'd have more, calm or more peace in my life. Well, paint the picture for me. What does your life look like when there's more calm and peace? Well, I'm getting up in the morning and I'm feeling better and I'm actually doing some exercise or getting out in the sun and taking a walk or whatever it is. And that becomes the concrete goal of treatment. So I think this is a really important first step that's often glossed over. It's like the patient giving themselves permission to change and orienting where they are on that path towards change. Secondary to those quality of life and functional outcomes, we have a reduction of symptoms, which cannabis is usually quite good for. But in the end, when I look back with patients, those are the things that are less important, the symptomatic improvements, whereas these life changes and their relationship with themselves and their life are the more important. Improved safety and tolerability of other treatments is a big one, especially in cancer care, but certainly in other fields. A lot of people are on numerous treatments that cause side effects, and cannabis can ameliorate those side effects. And then, of course, one of the main reasons people are coming to me is because they're on drugs. They want to get off those drugs and use cannabis instead. And one of the beautiful things about cannabis is we can usually implement it without changing those other drugs at all, get someone feeling much better and kind of establish the stability in their life, and then start tapering off those other drugs with the cooperation of the other prescribers, which, of course, is always a great opportunity to educate your local colleagues about cannabis when they see their patients asking to get off these drugs and another provider calling to talk to them about that. It really gets them interested. So what is cannabis medicine and why is it just so different from what we were trained in during conventional medical training? Well, first of all, this is a multi-compound medication. This isn't a single molecule, and each one of those multiple compounds has multiple targets in the body. We're already like in a whole nother realm of complexity compared to this traditional, monotherapy, single molecule medicine with single targets in the body. This is way different, and of course it makes a lot more sense considering what we know about the complexity of our physiology. With cannabis, we're able to interface with the endocannabinoid system, this homeostatic regulatory system, and other targets in the body. I always suggest that we treat the patient and not the diagnosis. You could have two people with Crohn's disease, and their treatment regimens may look completely different based on their symptoms and who they are and how they are. You could have someone with Crohn's and someone with PTSD who have an identical treatment regimen. It's really not about the diagnosis. It's about the individual. And then, as Deborah Malka was talking about yesterday, some of these barriers to healing, and I think Michelle Sexton brought this up also, these are basics, right? If somebody's not sleeping, it's going to be hard for them to heal. Let's address that first. If they're having trouble being active, if their social and spiritual connection is impaired, that's a high impact area for intervention. Now, just back for a second to this multi-compound, multi-target medicine. I'm going to show you a graphic on the next slide that's not about cannabis. It's about curcumin, which is just one ingredient or one compound found in the herb turmeric, but it has multiple targets in the body. And it's about how that one compound, curcumin, can relate to Alzheimer's disease, which is Alzheimer's disease is an outcome. There's multiple pathways that lead to that outcome. And among those pathways, there's protein targets that are receptors and enzymes. There's just so many ways that we could interface that. Taking something that complex and saying, we're just going to address one node, one part of that problem, it doesn't really work because we have so much redundant physiology. It makes a lot more sense, as Kevin Spellman has taught me to think about medicine with multi-compound, multi-target drugs, that we would love, it'd be much better to give a dozen different little nudges on the system all in the right direction than trying to poke one of these nodes really hard over and over again. It just doesn't make sense. So here's the image, the network visualization of the interactions of curcumin with Alzheimer's disease. And so, you can see these different proteins, different pathways, all these different areas that could be targeted for intervention, and one compound can do that. Now, if we talk about cannabis and Alzheimer's disease, this would be a much, much more complex network diagram because of all the different compounds with all their different targets. So I'm inviting you into a zoomed out perspective of medicine that embraces this level of complexity and also has some trust in the health. Trust that in this complex system, there are mechanisms embedded in this system that can solve its own problems, that can restore balance and address, recover from injuries and illness. And that if we interface with the system in a way that honors that innate health, we might get better results than what we're seeing in the rest of medicine, but that's not going to be very hard. So how do we talk about cannabis dosing? It can be challenging sometimes. Say if somebody's smoking out of a bowl, we're talking about maybe the number of inhalations they're taking, a few, frequency, number of times throughout the day. There's certainly plenty of homemade and artisanally made liquid preparations that may not have been lab tested. I think the best we can do is stay focused on which batch it is and how many drops they're taking. Sometimes people are using these concentrates. It kind of makes me chuckle, but it also, I'm sure a lot of you know about a lot of stories of people that have tried to take a half rice grain and might have taken a full rice grain and not had a very good time with that. This stuff is just so potent. Trying to measure it out in rice grains is probably not the best idea unless you already have a high tolerance and can handle large doses. And what I often do with my patients who inhale cannabis is talk to them about how much they're using per week. Like, are you burning through 1/8 of an ounce a week or a full ounce a week? And that gets me oriented to kind of their dosing. But of course, as the cannabis field matures in your local area, you'll have more and more opportunity to talk about things like how many milligrams of THC are you using, how many milligrams of CBD, and some of the trace cannabinoids, certainly the acidic cannabinoids. Now, when we talk about milligrams, first of all, in my practice, when I see an adult, I don't dose an adult based on their body weight. I don't think that that's important. Everybody's so different. There's a lot of inter-individual variability with cannabis, and so it doesn't matter if somebody's big or small or male or female. If they've never tried cannabis before, it's really hard to predict, are you a 2 milligram person or a 20 milligram person, just by looking at them and talking to them. But if I do take what I've seen in my practice and put it into dosing by body weight, this is the range that I've been exposed to for safe and effective doses. So 0.01 milligrams per kilogram per day, all the way up to 50. So for someone that's about 70 kilograms around my size, this might mean that, and these are outliers, but some people might do well literally with 1 milligram per day. I've seen it before. Some people are ultra sensitive, and that's all they need to get great relief. It might be a milligram of THC before bed. They're feeling better the next day. 6 months later, they're doing even better. I've seen it. I've also seen people my size take 3,500 milligrams per day, walk into my office, and I'm talking THC, non-impaired, saying they feel 10 years younger. I mean, it's really possible. And even though this dosing range is incredibly broad, beyond what you might see for any other medication, it's still well below the dose that researchers have had to use when they try to kill monkeys with THC, which is very hard to do, as you can tell. So we're, even though it's a really wide dosing range, we're still way below this, true toxicity. Now, if you give someone that's cannabis naive 3.5 grams of THC, there's going to be a short-term acute toxicity, but it's not going to cause any brain damage or organ damage or any lasting injury to them, except for maybe a psychological injury that might make them never want to use cannabis again. And that's a real problem for some people, who get a cancer diagnosis and their friend hands them a tube of RSO and they never want to touch the stuff after their first half rice grain. But anyways, within this wide, safe and effective dosing range, we experience nonlinear dose-response effects. And this is very common in cannabis, something I want all of you to understand. So this is just a simplified diagram of a biphasic dose response. Biphasic means there's two phases in this relationship between the dose and the response. So as the dose is increasing, people might feel stronger and stronger benefits, get better and better relief up to a certain point. If they increase the dose beyond that, they actually start losing the benefit of cannabis. And what's not depicted in this diagram is that there might be an emergence of more side effects at that point as well. So everybody seems to have an optimal dose that can shift over time. For a lot of people, as they get started when they're more ill, the optimal dose is higher. Over time, as they heal and get more well, that kind of slides down. But when they avoid going past this optimal dose, they can retain efficacy with treatment for years or decades without building tolerance, without losing any of the benefits. So if you see people that have escalated to a certain point where they're starting to lose the benefits of cannabis, it doesn't really make a lot of intuitive sense to people. Like, people tend to think this medicine was working for me really well before, now it's not working so well, I'll just increase the dose a little bit. So they increase the dose, they might get a few days or a week of better benefit, and now they're receiving even less benefit after that. It's non-intuitive to think, oh, this medicine isn't working as well, I'm going to reduce the dose. Like, people tend not to think that, but I want to get you thinking that way because we see it all over cannabis. Here's a rat study that administered various doses of THC and measured the locomotor activity of the rodents. And so you can see in black, this is the baseline activity, how much they're running around in an hour. Give them a very low dose of THC, 0.2 milligrams per kilogram. So that's moderate for humans, but very low for rats. Their activity level goes down, right? So this seems to have a relaxant effect. As you increase the dose of cannabis, of THC to 0.51, 1.52, you actually see locomotor activity increasing above baseline. And then as you continue to increase the dose, it goes down again to a little bit below baseline. So this is a triphasic dose response effect, and we could also say that there's a bidirectional effect here, meaning that compared to baseline, THC could be used to both lower and increase activity. So we could go in two opposite directions here. Now, if locomotor activity was analogous to anxiety or muscle spasms or something, you might look at this chart and think, well, we could get a reduction in their spasms at a very low dose or at a very high dose, but it's actually going to work better if we use the very low dose. And if we kind of use the wrong dose, we might make their symptoms worse. Furthermore, beyond this kind of peak here, we see the emergence of catalepsy, which is remaining still in an unusual position. And that might be analogous to a side effect like sedation or fatigue, common side effects from cannabis. So I think the point here is expect the unexpected. Expect that as you titrate doses you can get bidirectional and biphasic effects. And then I also want to point out, and I did this yesterday as well, so I won't dwell on it, but there is something extraordinarily interesting happening at the ultra-low dose range of cannabis. Now, these are rodent studies. 2 micrograms per kilogram is amazing too. Give someone a spray and they can activate their inner pharmacy to recreate what the real medicine could do. I think that's very valid. And there's been a couple papers that have looked at the mechanism of the placebo response and implicated the endocannabinoid system in that. Of course, think about it. Any drug that's ever been tested against placebo, there's going to be at least one person, but usually more like 30% of the group in the placebo group that can literally recreate the effect of that drug with their inner pharmacy. And that spans across medicine. Now, what physiologic system do you know about that might be responsible for these, diverse, effects in the body that can affect any organ system in any direction? It's the endocannabinoid system. Now, with CBD, we also have some evidence of this biphasic dose response effect, but it based on the studies we see with purified CBD, it tends to happen at a much higher dose. So this was a study of the anti-anxiety effects during public speaking. And you can see 3 doses were administered, 100 milligrams, 300, and 900 of CBD, also compared to placebo and clonazepam, the benzodiazepine. And the 300 milligram dose did great. It did even a little better than the clonazepam. 100 and 900 did not. So this biphasic effect is there for CBD as well. I mentioned bidirectional effects, so this can show up as the same medicine causing opposite responses in different individuals. You've seen this. 2 people smoke the same joint. One says, "Oh, this is a great uplifting one," and the other one says, "I'm ready for bed." So also, just going back to the early 70s in the literature with THC, anxious subjects becoming less anxious and more euphoric, non-anxious individuals becoming more anxious with the same dose of THC. People report this all the time, sedation versus stimulation, appetite stimulant versus suppressant, and so forth. But then we also see bidirectional effects in the same individual. So give someone the right dose of cannabis and their anxiety goes down, give them the wrong dose and it goes up. Same with nausea. Actually, if you look at THC overdose, it's pretty much characterized by all the symptoms that THC would help in an appropriate dose. You see, people becoming anxious, having pain, having spasms and twitches. They get nauseous, they can vomit, they can have diarrhea, they can be confused. So there's these paradoxical or bidirectional effects with THC. The setting can also precipitate a different effect. Same dose, same person in one setting makes them relaxed, and another setting like the oral surgeon's office makes them anxious, and that was actually studied. And then finally, even if you think you're getting the same dose, 2 different products could produce very opposite effects. Now let's talk a little bit about THC and its therapeutic window. So people that are brand new to THC are more likely to have adverse effects to it. There are some exceptions to this, and I'm curious, I'd like to take a poll. Who here, the first time they used cannabis, did not feel it? They really know they inhaled it and they really didn't feel anything, right? And then it was like the second or third time, right? So there is something, either it's a reverse tolerance or it's some type of perceptual capacity to recognize the effects of cannabis, or maybe both of those. But this is common. A lot of people, their first 2 administrations feel nothing and then they get the effect. But beyond that, in general, people that are new to cannabis are likely to have adverse effects, more likely than experienced users. It's been shown that THC can widen its own therapeutic window. So what do we mean by therapeutic window? This would be the dose that produces benefits and the dose that causes side effects. And so what we want is for patients to be somewhere inside that window. And when they start off, that window can be narrow. We don't want to overshoot it. It's not the end of the world, but we prefer to help people experience the upsides without the side effects of cannabis. Now, part of this ability for THC to widen its own therapeutic window may be due to heterogeneous tolerance building in various areas of the brain especially, but also the rest of the body. So for example, one of the more common complaints of people that are having side effects when they first start is either dizziness or clumsiness. It's some kind of a psychomotor discoordination. That rapidly goes away for most people. Within the first week or so, they're not feeling that anymore, and perhaps that's because in some of the motor centers of the brain, there's a more rapid tolerance building to the effects of THC than in some of the other areas, like the pain areas and the limbic areas that control anxiety and memory. So it can be useful to build tolerance in some of the negative effects. Therapeutic effects may be more resistant to tolerance development than side effects. So I just want you to remember this, because this comes into play when we develop a dosing regimen for people that are new to cannabis. We want to give THC a chance to widen its own therapeutic window. Now, what about combining THC and CBD? Here's one study that looked at nabiximols versus a spray that was just THC. So you can see two different dosing regimens here. These were patients with cancer pain that had pain despite using opioids, similar to that previous study, split into 3 groups: placebo THC spray and the regular nabiximol spray, and they were allowed to titrate their dose over 2 weeks. And you can see on the chart that the THC users ended up at around 10 sprays per day, so that'd be 27-ish milligrams per day on average. The THC CBD combination users ended up at around 11 and a half sprays, so that's a higher number of total cannabinoids, but a relatively similar dose of THC, and then placebo was a little higher. So what were their outcomes in terms of pain? Well, I think that this middle section on the bar graph is the most important. This is the percentage of patients that achieved at least a 30% reduction in their pain. And you can see that the group that received the regular nabiximols, that 1-to-1-ish formula, there was a much higher response rate. They were able to titrate up to a higher dose, not a much higher dose, but a bit of a higher dose, and overall they were more likely to have this kind of landmark. In most pain studies, 30% reduction of pain is considered clinically significant. The adverse effects were pretty similar in these two groups. So what do we see here is a slightly higher dose, better efficacy, and similar or less side effects when looking at people that self-titrate either a THC dominant or a combination product. I think in most situations, CBD makes THC more powerful. So another way to think about this is that CBD can widen the therapeutic window of THC. Now, when we're talking about severe side effects, the difference is even more pronounced. So toxic psychosis would be not a permanent psychosis, but the transient psychosis people experience from overdosing on THC. And if you look at studies of synthetic THC, Dhanabalum, you can see that on average that toxic psychosis threshold is up around 17, 18 milligrams. Give that many milligrams of THC to someone that's not used to it, and they might go, kind of psychotic for a little while. However, in the studies with Sativex, the safety studies, the threshold was closer to 50 milligrams of THC that caused that toxic psychosis. And in theory, it's because of the presence of CBD at those levels that kind of widen that therapeutic window. So in general, when, say, someone is using versus a combination versus CBD dominant, one thing to consider is the total number of milligrams, because you're going to need more. This is important because cost effectiveness is a strong motivator for a lot of our patients. And so if you're leaning too heavy on the CBD and they're taking a lot of milligrams per day, I don't think that the sedating effect is directly related to the CBD, but probably more likely related to other compounds that are coming in some of these CBD formulas, or potentially, like in certain cases like seizures, the drug interactions. Many people can feel 5 milligrams of CBD. Maybe 10 milligrams is a more common threshold for saying, like, yeah, I really feel that I took something there. Some conditions respond, to the triple digits, 500 milligrams per dose. 1,000 milligrams per day of CBD has been studied in psychosis and schizophrenia, very well tolerated. So another super wide dosing range there. Now, this was an interesting study. I bring this one up because most studies indicate that, well, when you combine THC and CBD, you're going to get a reduction in the side effects and an augmentation of the benefits. And I think in most cases that's true. This study used vaporized cannabis, THC dominant, mixed THC and CBD dominant, and placebo cannabis as well in fibromyalgia patients. And what they found, actually, I'm going to spare you all the details, but what they found, they looked at the pharmacokinetics, so in the blood, what were the levels of THC and CBD doing after vaporizing these amounts, and how did that correlate with reductions in pain? And they actually found that having the CBD in there increased the concentration of THC in the blood because it made it slower to break it down, but it actually diminished the analgesic effects of the THC. So my point here is that CBD can often enhance the benefits of THC, but it can also block the benefits of THC for some people in some cases. So are CBD dominant preparations enough? I think for people like me and Dr. Malka that started practicing in the age of THC, we've probably been a little bit more hesitant about CBD dominant treatments producing the phenomenal results we've seen over the years with THC and mixed treatments. I'm starting to see more benefits. It might take a little longer for patients to get there in some cases, but I've been gradually more and more impressed with the effects of CBD dominant preparations. Here's some data from Stacy Gruber, not published yet, but she's presented it at several conferences. This was a full spectrum CBD custom made from NIDA-grown cannabis, 10 milligrams 3 times daily, given in the form of an oil or a tincture. People with anxiety experienced an 80% reduction in anxiety after 4 weeks, significant improvements in depression and mood, and many cognitive domains, so they were actually mentally performing better, except there was one learning test where there was a very small detriment. There was a longitudinal extension that went out to 6 months. They continued, those improvements were sustained at the 6-month mark, and they had 0 adverse events, significant improvements in sleep and several quality of life measures from 10 milligrams of CBD 3 times a day. Pretty powerful. There's been some other studies with similar results. And then here's one on diabetic neuropathic pain. This was a sublingual CBD. The dose was 20 milligrams 3 times daily. 31 subjects, again, open label, so sure, there could be some placebo effect in there, but what they found was that there were no adverse effects. Everyone in the study, all 31, had a reduction in pain. About a third of them felt better after 24 hours. That might have been the placebo response group, I'm not sure. And then 2/3 really noted the benefits at 7 days. All 23 subjects that were taking pain medications requested to reduce or stop their pain meds, but they were told not to because the study design didn't want them to, because it would skew the results, and I think a couple of them did anyways. But if you look at pain scores, there was really no difference, orange or yellow, whether it was the patients that were taking the medications or not. There was a reduction in pain. There was so this is a reduction in average pain and a reduction in the maximum pain. There was also a reduction in anxiety that was pretty significant. Again, these were patients with neuropathic pain, not complaining about anxiety, but their anxiety scores went down and their sleep scores improved. This is 20 milligrams of CBD 3 times daily. So I think that there is value in the use of CBD at doses that are affordable and accessible to patients, and especially patients that don't do well with THC or don't have access to THC. My question is always, though, is it the CBD that's actually doing that? Maybe, maybe not. I showed you that data earlier on the ultra-low dosing range of THC. You're certainly achieving that with these CBD preparations that are broad spectrum. They contain less than 0.3% THC. So something that's 0.3% THC at 20 milligrams 3 times a day, somebody's still getting around a 0.5 milligram of THC 3 times a day. Could that be doing the trick? Is it that or the CBD? You know, here's a study of a placebo-controlled trial over 8 weeks with 17 women with fibromyalgia. This was out of Brazil, and they were given a THC-rich cannabis oil made from the White Widow variety. Their initial dose was 1 drop daily. 1 drop was 1.2 milligrams of THC daily. At the end of that 8 weeks, the average dose was 4.4 milligrams of THC daily. 4.4 milligrams of THC daily, probably spread over 2 to 3 doses, right? So we're talking like maybe 2.2 or 1.8, milligrams of THC per dose. Not that different from what people can get from CBD dominant formulas. Here's their total fibromyalgia score in the cannabis group. It went from 75 down to 30. In placebo, it went from 70 to 61. That's a pretty big difference there from that. So my point is that a little bit of THC can go a long way. You really don't need much a lot of times. Participants were not instructed to reduce other medications, yet 3 spontaneously reduced antidepressants and 1 reduced a benzodiazepine. Why? Because either the cannabis was working so well they didn't need that anymore, or in the case of the benzodiazepine, the synergy might be too strong. Like when you add THC to a benzo, the benzo starts feeling stronger and people tend to want to pull back on that. Reports of improved well-being, more energy for activities of daily living, subjectively reduced intensity and frequency of panic attacks in patients with fibromyalgia. Now, I want to just point out that we've spoken about THC and CBD, and certainly those have gained the most attention, but there are many other cannabinoids and classes of compounds in this beautiful plant, and I thought I would just show some pictures zooming in on the trichomes there. So we don't have time to talk about them all in this lecture, and I don't think it's important for you to quantify all of these with your patients, but you might be interested in talking milligram doses with some of the major contenders like CBG, CBDA, THCA. I think those are probably compounds that your patients are having exposure to. So I want to talk about how to dose people that are new to cannabis, and these are kind of 3 very basic rules that I've followed with most of my patients. I start subtherapeutic, so I warn them, I set the expectations. You're probably not going to feel anything on your first dose. I want to aim for a dose that they really aren't going to feel at all, or maybe just feel just the tiniest little bit. It gives them some confidence. They're not so scared when they take their second dose. Then we start titrating up. Once they start experiencing some benefits, instead of continuing to titrate, I have them pause and just feel out those benefits for a few days. Now, what could be happening during those 3 days? Well, we talked about it before. It's the widening of that therapeutic window. So not only are they becoming more comfortable with their treatment, but potentially they're starting to build some tolerance to the side effects so that when we proceed with more titration on day 4, they're able to go further without getting the side effects. This is a picture of my grandma, Elaine, with my dad. This was her 92nd birthday. She had fibromyalgia, arthritis, and depression. Throughout her 70s, she was on multiple drugs. She was pretty miserable. In her early 80s, we got her on a cannabis tincture. She never knew what it was. It was her herbal pain formula. She was in an illegal state. Her son, not my dad, but my uncle, produced it for her. We didn't know the dose. There was no testing labs. Every batch was a little different, but the same recipe was followed. We used this dosing regimen. We started her at 1 drop. She never had side effects. She got off most of her other medications. Her quality of life improved. She became warm and loving. She started making jokes. I felt like I had a real relationship with her because she wasn't so miserable. It was really a profound change. And I can say very clearly that her 80s and early 90s, she had much better health and quality of life than she had in her 70s. It was really a big difference for her. And I don't think she ever had a side effect from cannabis. It was all upside for her. So this is really doable. Some tips, starting with an oral preparation, literally just 1 or 2 milligrams. Up to 3 times daily. It doesn't have to be 3 times daily for everyone. Often I just start at night and then add in the daily dosing, and I'll show you some of that on the next slide. If there's reason to be using inhaled cannabis, again, it's just 1 or 2 inhalations up to 3 times daily. If you don't know where to start on a ratio, 1 to 1 is an easy place to start. You can adjust it later. Track and document the response is really important. We got some of these cannabis journals up here. We have worksheets on healer.com. I think that feedback loop is really important for patients to see what's changing. And if they're not getting good sleep, then we start with helping them get good sleep. Now I want to show you, this is an interesting titration protocol for nabiximols sprays, what's being used currently. Each spray, again, is about 2.5 each of CBD and THC. And you can see here on day 1, they take just 1 spray in the evening. On day 2, they take 1 spray in the evening. On day 3, 2 sprays in the evening. On day 4, 2 sprays in the evening. It's not until day 5 that they start 1 in the morning, 2 in the evening. Then it's 1 in the morning, 3 in the evening, 1 in the morning, 4 in the evening. And they don't go to 2 in the morning until they've already been to 4 in the evening. So again, this is a different strategy for allowing that therapeutic window to widen, allowing them to maybe experience some of the adverse effects while they're asleep, so it doesn't really matter, and then moving on. Now, this is not how nabiximols started. This was an adjustment after they had some pretty significant side effects in their clinical trials related to a higher dosing regimen. Labels are off on this. I'm sorry. Some of these bars are unlabeled. I'm not sure what happened to them. But what you can see here is in blue, before they changed, these are the MS studies, before they changed to that dosing regimen I saw on the last, I showed on the last slide. So you can see much higher levels of dizziness. Those came down after they adjusted their titration schedule, somnolence, dry mouth, vertigo, and I forget what those other 3 were. But in general, just way lower side effect rates after getting the titration right. Now, when people come in and say, I don't want to get high at all, I just want relief, it's okay. You can say, that's fine. We can do that, no problem. We were doing that just fine before CBD ever came along. You can do that with just THC-dominant preparations if you dose them carefully. So low dose of THC after widening the therapeutic window, or if you're using like combinations of CBD and THC and people really want to avoid that psychoactivity, you can lean into the CBD a little bit. The raw cannabis I've found extremely effective, no psychoactive effects there. And then if it's a localized problem, you might not need to treat them systemically yet, and you can start with just a topical cannabis. It's a nice kind of entry for people that are nervous about using cannabis. Then, you know, they follow up 3 months, maybe 6 months. Eventually, we find the right time to bring up the fact that they probably ought to experience some of the psychoactive effects of cannabis. And it's nice because at that point, often what I'm doing is saying, you know that dose of THC that you're taking it before bed? Once a week or so, I'd like you to take it a few hours earlier. And tell me how you feel while you're still awake and what that evening is like for you. And they come back saying, that was wonderful, you know? It felt like a glass of wine or two, but much better. And it wasn't like this hallucinogenic thing I was thinking that it was going to be. You know, people build it up in their mind and get scared of it. And it's nice to, when ready, like show them the benefits. What are the benefits? If you look at the clinical studies of cannabis and cannabinoid-related compounds, euphoria is almost always listed in the side effect profile. Now, what is euphoria? If you look it up in the dictionary, it literally means feeling good despite having an illness. Is that a side effect of cannabis? It's crazy. What is euphoria? Positive mood, relaxation, people laugh, they socialize, they kind of lose track of time, which I think can be really good for them. And then there's an intensification of these naturally rewarding experiences like eating, listening to music, watching films, having intimacy with their partners. Like these are important. People tell me that when they're high, when they're experiencing those psychoactive effects of cannabis, they have these epiphanies, like they become more aware of themselves, more connected to something greater than themselves, like God or the universe, whatever they want to call it, seeing their challenges from a different perspective and finding creative solutions and feeling more flexible mentally, physically, emotionally, and a greater capacity for change. These persist. So the cannabis wears off, they return to their so-called ordinary state of consciousness, but the lessons they've learned in that cannabis state of consciousness remain with them, and I think that's really beautiful. And I want to take the time to just go through, I know this is a really busy slide, but especially patients with chronic pain, I think it's useful to understand, especially if you haven't had chronic pain and been through this before, what it can be like, because people are often coming in with this bundle of suffering. That's much more than just their pain. So they have, remember, the nociception that comes to the brain, and then when it arrives at the brain, we categorize it as pain. We assign a meaning to it, like, oh, this is bad. Then we become fixated on it, so we're always paying attention to this bad feeling, which of course exaggerates its aversiveness. Then we have anxiety about it never going away and about it getting worse in the future. And from all of that emerges all these pain-related behaviors and consequences, like not moving around or being active, not knowing that through nonverbal communication and sometimes verbal communication, they're demonstrating their irritability to the people around them. Then those people are reacting. Sometimes they can't help it. This can lead to social isolation and interfere with relationships. And then also the absenteeism from work. And I just want to pause there because I know cannabis is a great medicine, but I think that meaningful work might be an even more powerful medicine. And in my practice, when I've seen cannabis help people get over that threshold of disability and get back to work, it is an incredible celebration, and their health skyrockets from that if it's kind of work that they love. And so in this pain bundle, there's this lack of recognition and ability to modulate these distinct aspects of the illness. What happens after they use cannabis, and I think especially enjoy some of the psychoactive effects of cannabis, well, they have the nociceptive sensation. It doesn't go away. It's usually described after they interpret it in the brain as less intense and sometimes less bothersome. They can categorize that as an ongoing part of life. Like there's more acceptance and less judgment with a more neutral assignment of meaning. They can see their pain as a companion or a teacher instead of a tormentor. Decreased attention on the pain. That's, I think, one of the main strengths of cannabis. It lets people still experience the pain, but they describe it as being like in the back burner, or it's just somewhere where I don't have to stare at it all the time. Decreased fixation on the pain, which allows for increased fixation or perception of the things in their life that are beautiful and naturally rewarding to them. Less anxiety about future symptoms, less of those pain-related behaviors which support their social interactions, less overall experience of suffering, and perhaps most importantly, having been through this journey, a recognition of these distinct aspects of their illness and their capacity to modulate them, to address these different aspects instead of this one big kind of impenetrable bundle of suffering. So moving on from the psychoactive benefits of cannabis, if you have someone that's been using cannabis for a while, but now something's changed in their life and they need to use it more medically, usually the first step is to explore, do they have tolerance to cannabis? You can figure that out with a few questions, and if that's the case, we want to reverse that tolerance. I'll tell you how to do that in the next slide. So we basically want to take them from here back to here. A lot of people that are experienced with cannabis are only using inhalation. If they develop symptoms that are all day, everyday symptoms, it doesn't make sense to treat that with a rapid-acting, short-duration method of delivery in most cases. So you want to train them to use some oral or oral mucosal preparations. And then a lot of people that are familiar with cannabis are actually not familiar with CBD and some of the other cannabinoids. And so introducing that to them. Now, how do we do this reversal of tolerance? And when do I think about it? So it's a 6-day protocol. I have it on my website. It's free for everyone. Basically, when I see someone that's smoking like more than 1/8 of an ounce a week, or certainly more than 1/4, if they admit through interview that they've built tolerance and lost efficacy with cannabis, and in general, if they just seem out of balance in their relationship with cannabis, because it's a way of like generating this respect for the plant, and then the plant respects the individual in return. That's what it looks like to me. The results are you get to use less, have more benefits, less side effects, save money, and improve your self-awareness. So, a lot of upside to taking 6 days to do this. Back in, I think it was 2011 or 12, we surveyed 48 patients who did this. They reduced their dose after 6 days by more than 50% while reporting that they got the same benefits or stronger benefits. So it really works. And you don't even need a 6-day protocol. I do that to enhance the self-efficacy in the patient. It's 48 hours of abstinence, basically. And this has been proven, at least in men with a functional MRI, that were heavy users, stop for 48 hours, those CB1 receptors come back in the brain to near baseline levels. But then what we do in the next 3 days is a very slow and careful titration process that gets them in touch with how their body's responding to cannabis and potentially takes advantage of the the potential for THC to upregulate the cannabinoid receptors in the endocannabinoid system if you start slowly. And then on day 6, they just use as much as they want and realize, wow, that's half of what I was using before. Now, how are patients using cannabis? Well, in this case, how are they using it to treat pain? Here's a survey of 1,300 people. What I wanted to point out is that 93% were using 2 or more routes of administration. 72% were using 3 or more. This is the norm, right? Most patients that are fully dialed into their cannabis regimen are going to be using more than 1 route of administration. And this is analogous to what we see in medicine with, like, say treatment of pain. Somebody's got a long-acting opioid, then they got a short-acting opioid for breakthrough pain, they got a muscle relaxant for their spasms, they got a sleep aid, maybe something for anxiety. Well, cannabis can do all of those things. But this one medicine can do those things better, perhaps in different forms. So they might have one formula as their kind of standard one, and a different one for when pain's real bad, or maybe inhalation for breakthrough symptoms, or maybe it's going to be a bigger dose of CBD when they're feeling anxious. Whatever it is, there's usually going to be multiple products, multiple routes. And my time's just about up, and this has been covered already, so I'm just going to really fly through some of the delivery methods. Inhalation, like I mentioned, rapid onset, short duration of action, excellent for breakthrough symptoms, excellent for episodic symptoms, excellent for the spiritual psychoactive effects of cannabis, excellent for augmenting non-pharmacologic treatments, like taking a couple puffs before yoga or physical therapy or meditation or sometimes counseling or therapy. Then we have the oral mucosal and enteral delivery method, which is going to be slower to kick in, but longer acting, better for long-lasting symptoms. Anything that stimulates appetite and looks this delicious, I think, is probably not a great idea for most of our patients. As many of you know, this is where a lot of people run into problems and have that experience that makes them never want to come back to cannabis, so we always try to avoid that. But this would be ideal for staying asleep. Inhaled might be better for falling asleep in some people, but a big problem that people have, using cannabis inhalation for sleep is you ask them and they say, like, yeah, I fall asleep great, and then around 3 in the morning I start to get restless. Why? Well, that smoke wore off there. So you could have some smoke and have some drops, and now you're sleeping through the night. And then there's topical, transdermal, and rectal delivery. I'll just mention, I think there's good potential for transdermal. It tends to be expensive, and I've seen few pharmacokinetic studies that actually prove it's getting absorbed, even though some patients that have used patches really like them. As far as rectal cannabis goes, or vaginal for that purpose, I think that local effects can be pronounced, pain, itching in the area. Some people are going to absorb some amount of this systemically and have a nice systemic effect, but I do want to caution, because a lot of times where we see rectal being used is in patients that think they need a very high dose of cannabis, say for treating cancer or something like that, cannot tolerate that very high dose when taken orally because it produces these strong psychoactive side effects, and then realize, oh, if I put that same dose in rectally, I don't get those psychoactive effects, so I'm getting my cannabis with all upside and no downside. However, and there's some justification for that. The proponents will tell you that, well, when we take something orally, we get this first-pass metabolism, which means all the blood from the gut goes to the liver. In the liver, the THC is converted to an active metabolite called 11-hydroxy-THC. It might be a little stronger than the real thing, than the regular THC. It's not that different, the 11-hydroxy. I don't think that's a big enough reason for rectal to be so different than oral. What's really happening with rectal administration is they're just not absorbing it, because if they were, that THC would be getting to their brain and they'd be feeling it. So it could be a waste. And then I do want to just mention, we got just 2 slides left, cannabis tea. So many people forget about cannabis tea or have never heard about it. I told someone about it yesterday, and she was just like, oh my God, I love drinking tea and I love cannabis, and I never imagined putting these two together. This is a traditional delivery method in cultures that have used cannabis for a long time, and it's considered the way to use cannabis as a tonic. The THC has very low solubility in water, so you're not going to get a lot of THC unless you maybe add a creamer or something for that lipid-soluble layer. But but you will get THCA, you'll get CBDA in significant doses, and it's kind of safe, effective, rapidly absorbed. What I'm showing in these graphs down here is the blood levels of CBDA versus CBD over here. So you can see CBD blood levels in green, CBDA in red, and then over here THCA in the orange, and THC in black, which you can barely even see at the bottom. My point with showing this is that the acidic cannabinoids are absorbed somewhere between 10 and 50 times better than their neutral counterparts. Now, the acidics may not be as impressive on their first sip. You know, some people, when they first couple days using THC, they're really impressed. I find that with the acidics, it can take a little longer, some consistent dosing for a couple weeks before they really are feeling the full benefit. But I've been super impressed with these raw preparations. And when I say raw, the water at temperature at boiling is not going to be hot enough to cause much decarboxylation, and whatever it does decarb isn't really going to be soluble in the water anyways. There is a little solubility. I don't want to be misleading. You will get some THC, just not a lot. And then there's just all these different varieties of cannabis, and I think we can, you know, the categories of sativa and indica are probably not accurate. What's important to know? What's the CBD content? What's the THC content? Is this maybe a better one for daytime or a better one for nighttime? And then, you know, how do people respond differently? And I think the cash register at the dispensary speaks the loudest. Like, people with anxiety, what do they keep coming back and buying? That's what I would tell my patients to ask, so that they can buy, you know, those top couple things that are selling for anxiety and try those out, or whatever it is. I rarely am recommending specific varieties to my patients. I'm more asking them to go to the place where they're buying the cannabis and talk to the person there, but be very clear about what they're shopping for. And that's all I have for you. I hope that that was helpful in dosing your patients.
All righty, Sam's going to get ready for our next speaker, which is going to be Deb Malka. So in the meantime, I'm just going to remind some folks. We're going to have several of the speakers here: Deb Malka, Dr. Malka, Dustin Sulak. I'm trying to think of who else is here. Tamara Netzel, and Dr. Bridget Williams, who will be speaking later, are available for book signing for those who want to do that during the lunch break. Other than that, I also want to remind people there's a silent auction. It's going to finish up today, so we'll end that at 3:30. I'm military, 15:30. At 3:30 this afternoon, after the last break, we'll get that out. So, so if you want any of the things on the silent auction, get your bid in now. And last but not least, the CME stuff. Again, healthcare professionals, remember to fill that out. You've got the instructions there, so you've just got to follow through. Other than that, Dr. Deborah Malka will be talking about who's the patient, cannabis therapy according to age groups. Again, general ideas just to help people get started with this. Are we all set for it? Maybe one little glitch.
All right, thank you. Okay, back again. Hold the mic closer, and that sounds good. Okay, so we are running 10 minutes behind. I do have a 7-minute video that I wanted to share with you at the end. I don't know if we'll have time. We'll just see how it goes. But carrying on, the impetus behind this talk was that as I was recently writing my medical cannabis clinical textbook, I realized that as a holistic physician, I don't really view patients according to their condition. And almost every medical textbook, you talk about treatment of a patient by their condition. And that's not how I treat my patients. So I thought, how can I kind of condense some of this information about what to expect about treating different categories of patients. And so I have chapters in my book about what I learned about what to expect with different populations, and dividing these populations by age seemed like the most valuable to me, so that's what I'm going to share with you. Okay, I don't have much to disclose. I've worked for myself and I do free consulting. So I'm going to abbreviate some of this. As I said, we're going to look at how age can characterize a patient, what you can expect when your different age groups walk in, and they are. We're going to start with adults because they're pretty least complicated. So as an introduction to what to expect with a patient, we're going to start with the adult group, then we get into complications. So we'll look at pediatric 0 to 14. We'll look at youth 15 to 25. This is really complicated because minors under 18 have one set of rules, and then adults over 18. In some states, it may be over 21. I don't know. But I put them all in this category because they have a lot of the same characteristics, this 15 to 25-year-old group, and then the elderly age 60 and up. Okay, so basically, I'm going to give you a review of what characteristics to expect with this age group, what challenges, how to fix it, and a case report for each one, which is illustrative of what to do with that type of patient. So adults make up the majority of cannabis patients. Contrary to popular belief, for medical patients, most adults are in the adult range. We saw that with the Missouri statistics. 30 to 50 is an actual highest range for adult medical patients. Comparatively, recreational patients are usually in the highest numbers in the under 30 range. So we do see more medical interest as the person gets older. Also, interestingly, the elderly are the fastest growing population of cannabis patients. We'll see that shortly. Okay, so while the number of medical cannabis patients has grown throughout the country, recreational use has not decreased, which means we're actually adding to the roster of people who use cannabis as we increase medical cannabis access. The most important thing on this slide, and I really wish I would have put it in blue, is not only that we have to distinguish between recreational and medical use in adults, but medical, at the bottom, medical patients are different from recreational users in that these are the people that receive information about how to use cannabis therapeutically. That's going to be the most important thing for every age group. The most important thing you're doing is to help set the paradigm of this is a medicine, this is how you use it medically. You know, it's always been considered an accessory substance, whether you consider it abuse or not. It hasn't been considered in our society as a primary medical therapeutic intervention. To this day, that's still the case, and that's what we can do in our visits. Okay. So things to note about general adult medicinal therapy. Most adults that are coming to you for cannabis approvals, most, have started using cannabis recreationally. And so you have to have that switch in mind of how to get them to consider it as a medicine. Most have a preference for THC-dominant cannabis, and most have been introduced to smoking as their initial experience with cannabis. So those are all things we need to work with. The most common diagnoses for adults is pain, more pain. And followed then by insomnia where it's approved in that state, muscle spasm where it's approved in that state, and multiple kinds of mood disorders, ADHD, anxiety, depression, bipolar disorder, PTSD, I've seen almost every mood disorder. So put them all together as a category, and it's very large. Okay, so I am going to talk a little fast because I want to get to the video, but this will be online. What do you want to stress with your general adult medicinal therapy? You want to actually introduce the idea of how to assess for a positive outcome in the absence of feeling high. They're almost all going to come in there and say, well, I didn't feel anything. You know, even when you titrate to the low dose, or everybody's coming in there expecting to feel their effects by first feeling disoriented, whether they're fearful of that stigma or whether they're anticipating that stigma. That's what they're going to expect to feel, and you have to decondition them from that and explain a protocol for when to look for effects. Depends on the condition. You know, they can look for effects within hours, they can look for effects within weeks. You know, with decreasing neuropathy, they can look for effects within months. So you need to introduce that. You need to introduce alternative delivery methods. Maybe they haven't even ever heard of such a thing as there's a topical, etc. And you have to introduce alternative cannabinoids because they may not know about, especially about cannabinoid acids. Most people know about THC and CBD, actually, when they walk in for their first visit, but that's what they know. Okay. I include a discussion of tolerance with every visit. However, I'm going to skip it because Dr. Sulak just talked about that. He called it desensitization. And I really want you to see this video. Go right to the case report. So this is a typical adult visit. 50-year-old female using cannabis for low back pain, sleep, and mood. And this is a real person. This is a classical presentation with the 3 most prevalent conditions. You see them together a lot. She was diagnosed with lumbar spondylosis. She was primarily treating it by chiropractic, was taking no medications. Just for interest, this particular patient also had alcohol dependence and recent tobacco dependence. So here we have like 5 major things that we're going to treat with one medicine. She had been using cannabis 1 joint a day for 40 years. If she went to a psychiatrist, they would diagnose her with cannabis dependence. But she did not have cannabis dependence. Inherent in that statement, she'd stayed on that dose of 1 joint a day for 40 years. And this is a true story. So over the 5 years, we worked together. This is what happens when you provide for professional guidance. The dose did not change. The expected, anticipated outcome did change. So she continued to smoke only 1 joint a day. She reduced her tobacco. She stayed off alcohol, which she had recently stopped 3 months prior to before these 5 years that we worked together. She added some topical cannabis. Her mood and back pain stabilized, and her dose didn't change. So the reason I put this in here, other than we're treating like 5 different things, is that it's our job as medical providers to explain to the patient what the cannabis is doing for them and how very helpful it is and what they can potentially expect from the treatment. Because the expectation was, oh, I'm just going to, get high and relieve my pain a little bit. Well, if you tell them that this is actually going to help you stay off your alcohol and it's actually, all the good things, then you can affect outcomes by intention. Okay, so we'll move on to children next. There's actually little data that you can find anywhere in the literature about cannabis therapeutic use in children other than for pediatric epilepsy. There's very few studies done. It's hard to get those studies funded. You can't give kids pot, ethically, it's a real problem. But we do have some observational data that I can share with you. So over the list of registries for patients in different states, there's no one place I found this, but all the different states I surveyed had anywhere from 1% to 5% of their medical cannabis patients that were listed as minors. So they list them as minors, not as 0 to 14, so we're going up to 17. That's the best I can do. What we're dealing with pediatrics is that the patient's doctor almost entirely will warn against cannabis use in children. Pediatricians in general are really opposed to cannabis use. They think it's marijuana and that we're just talking about THC. Fortunately, that's not the case. We have many options of cannabis protocols that involve other cannabinoids and that involve dosing strategies. So we actually kind of have to really work with their doctors too. Nevertheless, patients bring in their kids and say, how can you help me? So we need to know the risks. There are real and valid risks for THC-rich products that can potentially affect neurological and brain development. So we don't want to use high doses, really, of anything, even CBD. You know, high doses of CBD have not been tested for 20 years on kids. We don't really know what it may or may not do to neurological development. So the one thing is to try to avoid high doses, if you can. There's a caveat to that. We'll get to it on the next page. As far as the risks for CBD, at least in the short term, going up to 20 milligrams per kilogram, the main side effect we see is drowsiness, sometimes loss of appetite. There is a potential for drug interactions at that high a dose. In general, there's no potential for drug interactions with low doses of cannabinoids of any kind, but this is a really high dose. And let me just see if it's on the next slide. Yeah, no, I'll say it here. So I'm going to go back. Am I going to go back? There. It's really important, especially with clients that you want to use low-dose therapies, is to use full-spectrum extracts. Because some of the need for the really high doses, like up to the 20 milligrams per kilogram for kids with seizure disorders, because you've taken out the full-spectrum synergistic components. So, for example, with seizure disorder, it's been shown by several groups that the effective dose for pure CBD is about 4 times the effective dose of the full spectrum extract. So, you know, you only need to go to 5 milligrams per kilogram, not 20. Okay. So other things with pediatric therapy is that, of course, you're dealing with, your client is primarily the parent or guardian, the adults. These are the ones that you need to work with to overcome stigma and provide education. Most pediatric cases are for seizure disorder. That's whether it's approved as the only indication in that state or whether it's in a state such as California where you can approve pediatric recommendations for any condition you want. The highest percentage of parents who are willing to come in and talk to you about using cannabis in their minor child is for a seizure disorder. That's what's most well known. However, there are a few other cases that have been documented, and these include pediatric cancer, nausea, pain, muscle spasm, mood disorders. That's increasing now with a higher percentage of minors with ADHD and autism spectrum disorder coming in for consultation. So the typical protocol for consultation includes the requirement to give a caregiver certification. That's California. I think it's true in every state that there's some specific form that the parent and guardian has to sign, and they have to be present, and they have to give their permission. They have to supervise the medication. All minors require that. The need for follow-up is always required, especially in pediatrics. And I would add to that is the need for interchange with the child's physician if they will at least talk with you is also essential. So that's pretty much the review until we get to the story. So this is a 10-year-old male with a mild form of epilepsy. He had absence seizures 20 times a day. Medications were of no help, and they had been discontinued 2 years earlier when he was 8 years old. So the parents came in and said, well, can you help us because we can't do anything. The medicines don't work. And we started with a CBD-rich tincture, 95%, 20 to 1, that's 95.5. THC, CBD, yeah, CBD, THC, sorry. And we started at 10 milligrams 3 times a day, and that gave a total dose of 2.3 milligrams per kilogram per day. We started at that because I thought we'd have to go a lot higher. And we didn't, actually. We tried. We went up to twice that dose, 20 milligrams 3 times a day, but we didn't see any improvement. So the seizures went down to 3 to 5 per day. That's the best we could do. I'm abbreviating all this because there's a lot of stuff. But anyway, at that dose, about 2 milligrams per kilogram per day, his seizures went down from 20 per day to 3 a day. We did this for 4 more years, still on 3 seizures a day. And during that time, we didn't have to, but we chose to add a sleep medicine. And this one was about 80% CBD, but it did have about 20% THC in there. And that actually helped him sleep. That little bit of THC, it's typically what I do with kids is give them a little bit of THC at night, not enough to make them even 20 to 30% THC mixed with CBD. They probably won't even feel altered. But it did help his sleep. So the parents were very proactive. They finally found a source for their cannabis from someone that gave them a formula that actually ended up containing 62% CBD, 2% THC, and 36% cannabinoid acids. They did this themselves. And you know, they get on these chat groups and find out that, oh, cannabinoid acids are really good for seizures. I think I'll try some. And they came back to me and reported that they were using this mix, but they had neglected to change the dose for the child's increased weight. So now it's 4 years later. So they were at like, 1.3 milligrams per kilogram a day, and we bumped them back up to 2, and did a few more years, and kid did great in school, good cognition, decreased stress, still on no medications. This is not one of your severe, Dravet syndrome type of seizure cases, but we see a lot of these. And this is not necessarily a really high dose, 2 milligrams per kilogram per day. That's like 1 milligram per kilogram per dose twice a day, and it worked out really well. Okay. Yeah, I don't think we'll get to the video. This is important. This is the most important thing I want to talk about, actually, is the youth group. The most challenging for me of any category of age group, because these are kids who are coming in who pretty much have been not only exposed to cannabis before, but either themselves begging their parents to get them their card, or they're just young adults. They have definitely been introduced to cannabis and like it and want to use it more. They've definitely been recreational users, and they definitely have some bad patterns. So that's the main thing we have to do, is reset that patterning. So there's actually very little data about cannabis therapeutic use in youth. There is much, much, much data about cannabis use in youth, and it's all recreational. So we do have some statistics that young people may start using cannabis at age 12. They keep increasing, this is just recreational use, increasing the percentage until like the early 20s, where 45% of the recreational users are in their 20s, 10% in their teens, and then it starts to go down. So it's not quite the most prevalent group, but this is where it all starts. So again, we still have the risk for cognitive impairment with growing brains and nervous systems. That's a definite risk, and they all want THC. They all, not all, 50% of 18 to 24-year-olds polled have dabbed before or knew someone who did. This may or may not be a thing in Missouri. Who here has heard of dabbing? Oh, well, you're a well-informed group. I'll just, for those of you who haven't, this is a thing that the kids like to do, some adults also, where they pour a drop of concentrate on a hot device that's glass or titanium. This vapor comes up, they inhale the vapor. Oil is 80% can be 80% cannabinoids. The strongest flower is like 20% cannabinoids, so you're getting 4 times the dose. And, you know, if you do that 2 or 3 or 4 times, you're really entering a very, very, very high THC intake situation, rapid intake. We'll come back to that. They did find that when they studied cognitive function, many really good studies have shown that cognitive function is not altered in adolescents who use cannabis in the long term. Of course, in the short term, but in the long term, they were not able to find sustained damage to cognitive function. And I really want to stress that. This reference that I put references other papers, so that's a good reference. And what they do try to put out is that there is decreased working memory and altered psychomotor activity in youth who use cannabis. Well, guess what? It's only during the withdrawal phase. But this is like part of the big title. So withdrawal was associated with, well, it is true that when you come off of a high dose of THC, you get foggy afterwards. and you have changes in psychomotor activity. They did find, actually, this particular study that exercise alleviated some of those symptoms. So again, exercise or anything that's going to help regulate endocannabinoid tone is a really good thing to do when you're doing a tolerance reduction or withdrawal. Okay. They also found that medical cannabis decreases illicit drug use in youth. Does not increase it, it decreases it. That's no surprise to us. Okay, what's the big problem with treating youth? Well, they don't want to listen to you, as in non-compliance with your advice, or if they're there with their parents, parental advice. They're almost all coming in with a practice of overusing THC and using it for recreational purposes and having the endpoint defined as getting high or getting altered. So that's the population you're working with. This then is a prime opportunity to begin the training about therapeutic use. They have never been exposed to it before. Say, wait a minute, I can actually use this thing that I like to use and find a way for it to actually make me feel good and more stable? Okay, maybe I'll listen to that. Or I'll hear it, but I won't let on that I'm listening to that. So it's true, this is true. So you want to talk about what is possible. You want to talk about the problem with smoking, even if you can get them to switch to vaping. You want to talk about the problem with dabbing. And you want to mostly be non-judgmental because you want to be their ally. This is stuff you all know. Need for follow-up is essential. And I can honestly say that I feel like I've been beneficial in 75% of the patients that I've counseled in this age group. Not all. 25% come in, do what they want. Next year, come in, do what they want. Next year, come in, do what they want, et cetera, et cetera. But 75%, if they start to feel better, they actually, they like it. So this is, I will never forget this case because it's outstanding. So this is a 17-year-old male who came in with anxiety, depression, insomnia. He came in with his mother. He'd been seeing a psychiatrist for these issues. He was currently taking Klonopin in the evenings. And his problem was that he felt paranoid, especially at night, and was afraid to fall asleep. But he's a really smart kid, honor student, doing well in school, but he was losing sleep and started to feel paranoid and couldn't fix it. The way he tried to fix it was he started to use more pot, because if some is good, more is better. So how much cannabis had he been using for 3 years? Now, excessively, he was dabbing 6 to 7 times per day. So that is, you know, every 2 hours, 3 hours, and smoking in between. And so now we're down to doing something like maybe every hour and a half. And of course he was getting up in the middle of the night and he couldn't sleep, so then he was dabbing some more in the middle of the night. This is a true story. He couldn't sit still at the visit. His leg was shaking. He was jumping around. And he really needed help. And he was happy to have it. He said, I don't know who to ask. We don't know who to ask. The psychiatrist is not helpful. So I told them that he was likely suffering from actual cannabis intoxication. Very, very, very rare. And not toxicity, but intoxication, which is a DSM-defined disorder that falls into some of these things with the hyperactive sympathetic tone and the inability to sleep and the shaking and et cetera. There's a whole bunch of stuff on there. So that his dose was high and he was intoxicating himself, and the way to treat it, of course, is to lower the dose. So what we did is that I allowed him to smoke, because we're going from an 80%, I didn't allow him, I suggested that he just get off dabbing, because we're going from an 80% substance to a 20% substance. So that lowers his dose down to 25% right there. So on 6-month follow-up, he was smoking, but only twice a day, because he'd already lowered his tolerance so much that, because I said, you can smoke as much as you want, you can't dab. You just forget that. So only twice a day, and he was feeling a lot better, and he was only smoking after school and in the evening, and he was already sleeping better and had less anxiety. But here's the really good point. That's really good right there. But the really good point is that the next year he had gone to college, gained weight, still smoked twice a day, but he was still having some anxiety. You know, an 18-year-old in college, of course, they're going to have anxiety for their first year. And I said, you know, you might really want to try CBD for your anxiety. And you can get a CBD flower and inhale that. And he actually got off THC altogether by choice. He found that his anxiety felt so wonderful from smoking a CBD cultivar that he's done with THC. This is possible. It really happened. Okay, we're going to move on to the elderly characteristics. They're the fastest growing cohort of cannabis users. Not that they're the most. 2018, there was only 4% of seniors 60 and above were using cannabis, but that was twice what it was a few years ago before that. So every year, their amount is up to doubling. Okay, what do we need to worry about with the elderly population? These are the things they say we have to worry about. When you read articles about safety of cannabis use in elders, of course, they're talking about safety involved in THC-rich cannabis. You have to understand that. Almost all of the risk management is about THC-rich risk. At risk for falls, cognitive deficits. Now, having said that, they do have a slower metabolism. That applies to all cannabinoids. So therefore, they may have a heightened sensitivity to cannabis of all types. And so you want to start with lower doses. So even being at risk for some things, a review concluded that the risks were really not associated with a higher rate of adverse effects as compared with adults in general. Now, elderly folks actually don't use a lot of THC-rich cannabis, so that's not something that we focus on a lot. If they do, the most common side effect that's been measured is dizziness. The rate of falls was not elevated. So why are these elderly coming in for a visit? What are they looking for? You know, you might think they want help with pain. That's what I would have thought. But statistics and my experience show that they actually are sick of taking all their medicines. And that's the truth. Their most common presenting complaint to me is, I'm tired of taking all these medicines, and then they go on to what the medicines are treating, but the first thing is the medicines. And indeed, 67% of seniors, including OTC meds, take 5 or more drugs, and 91% of seniors at long-term care facilities take 5 or more drugs, and they're just really sick of it. They feel drugged. They don't want to feel drugged, so they come in for cannabis, which is not a drug. So when they come in, they still have, in general, this older group, not everyone, of course, you have to deal with the fear of use and the stigma. I had a lot of patients at an elderly care facility or assisted living facility, and they didn't have fear of use. They were so cool, they would like pass the tincture bottle around the bridge table. And no, it's a true story. And pretty soon, almost all the people in this facility were using, it was a CBD-rich tincture, but, you know, once they see a friend using it safely, that's the best way to get over the stigma. Really. You can tell them all you want, but, you know, I'm really sleeping at night. So, primary complaint after the multiple medications is pain. Then, of course, we see osteoarthritis-specific pain, sleep disorders, mood disorders, and then there is some palliative care. Most people come in preferring non-smoke delivery, of course, because they are naive to cannabis, or they might say, you know, well, you know, a 65-year-old person saying I smoked in college days, but I don't want to smoke anymore. And so what else you got? Okay, this particular group, you really need to do follow-up and repetitive instruction. That's the biggest problem that we had. It's not that they wouldn't listen to the directions, it's that they need to be reinforced again and again and again. So if you're doing annual visits, then it's not enough for these old folks. Because they'll come back a year later, oh, is that what you told me to do? I didn't do it that way. So. Okay, here is a case report, and I'm going to tell you this great story. I don't think I have a 7-minute video of this visit. Maybe we can just make it available online. But this is a 103-year-old, she's my oldest patient, came in with her daughter complaining of constant nausea, and she also did have anxiety. She hadn't found any positive treatment for her nausea. She didn't like to take medicines. So this is an interesting thing about this age patient. They were raised coming back in the day before medicinal pharmaceuticals were even available. She didn't like medicine, she didn't trust them. She's not used to them, doesn't like them, don't want them. So she's only like on a blood pressure pill. That's it, 103 years old, but she was nauseous all day long. So I'm skipping through a lot of stuff, but anyway, I said, you can have a mouth spray or a lollipop. What would you prefer? And her daughter went out and got her some of each, and of course it was CBD rich. We know that CBD works well for nausea, and at that time, CBDA, which is even a stronger anti-nausea, was not available in the dispensaries, so she got a CBD rich lollipop. But what is interesting is that the dispensary, when we did follow-up, you know, of course, the CBD worked for her nausea. She's been taking it the whole year. But by the way, I'm also taking a quarter of a cookie to take the edge off for my anxiety. So this is a typical thing that happens when anybody goes to a dispensary, but especially for elderly, is that the person behind the counter will make suggestions. And pretty soon your old folks are taking something with THC in it. I mean, I could tell lots of stories, but we're out of time. So you do really need that follow-up. What is it you're taking? Because they'll always come home with something else. But anyway, she was happy with the cookie. She was happy with the mouth spray. We only met 2 times, one at 3 times. One at 103, one at 103 and a half, one at 104, and then I didn't see her again. But she continued to take mouth spray or a lollipop of CBD, and her nausea was totally gone. How's your nausea, dear? Oh, well, that's fine. You know, she even forgot it was a problem. So I think, yeah, we're not going to have time for the video. And we do have, well, cool. Wait 1 second then. Let me do this 1 page. Okay, this was going to be my summary, and then we'll play the video. So pediatrics, focus on CBD rich. Youth, focus on using cannabis in a therapeutic context. Adults, reframe recreational patterns. Elderly, focus on minimal psychoactivity. Reinforce a therapeutic plan. Follow up. Don't wait a year. And cannabis as a medicine means something different for each individual. But our input gives greater success. And now we'll meet Hermine. Her name was Hermine. Oh, I'll leave that open. Sorry. Hermine?
Yes.
Do you feel nauseous right now?
No,
Good.
not right now.
Not right now. How many times a day do you feel nauseous?
Oh gosh, I don't know.
Lots?
A lot.
A lot. Okay.
Yes.
Is it,
Mostly all the time.
okay. Does it help if you're walking around?
I don't know, because I don't do much walking.
It's really hard to get her to do anything anymore.
I'm
Okay.
lucky if I walk from my bedroom to the kitchen.
Okay. So mostly you're sitting, and when you're sitting, you're nauseous.
I guess I'm just nauseous
Okay.
all the time.
Can I have you stand up for me for a minute? Can I help you? Oh, good job. Wait. Let's stand up now. Are you nauseous now?
No,
Does that make it worse? Does that make it worse?
no.
Okay, you can sit down. So there's a lot of swelling in the abdominal area. You know that, right?
Yeah, I've noticed it the last month or two. It just seems like it's coming up this way.
And how long's the nausea been going on?
About 2 months, 3 months.
So has she seen a doctor about this abdominal swelling?
She saw him yesterday.
Is that in Santa Cruz?
Yes, in Arana Gulch, the
Okay.
Arana Gulch office.
You know, my memory is terrible.
Yeah, I know.
She's telling me about your doctor visit yesterday. I want to find out.
It was about, she's got a swelling over here, and we're going in for an ultrasound on this.
I'm not concerned about that. I want to know what's happening over here.
Yeah, and the tinnitus, it drives her crazy, and she has headaches. And I think they might be from allergies, environmental allergies, because she's always had sinus problems.
But what did he say about the abdominal
Nothing
swelling?
much. Not much.
Well,
I know. Yeah. We're going to go back next week. Because he took blood work, and he said everything came back within normal ranges.
she needs to have probably a CAT scan of the abdomen or an
Okay.
ultrasound.
Okay.
Because we have a huge, big abdominal swelling for 2 months, and we have nausea for 2 months. So these are related.
Yeah.
So we don't want to just medicate the nausea without treating the problem. So I'm going to write this down for you.
Because she's going in for an ultrasound on Tuesday.
of her abdomen?
He just wanted to do the lump, but I'm going to, he was, with the blood work that comes back normal and this is going on, no. I'm going to.
She needs to have the abdominal swelling followed up
Addressed, yeah.
immediately.
Yeah.
So follow up abdominal swelling. Is she still having regular bowel movements and urination?
It's about every, yeah. Urine is great.
Okay.
Bowel movements are every other day. Give her lots, at this time of year, lots of fruit.
Okay. Remy, does your belly hurt you?
No.
Because it's swollen. Did you notice that?
It's huge.
It's huge, right?
I have a terrible time getting my shoes.
Yeah.
Well, I can't put my stockings on anymore.
So I've asked Fox to take you back to the doctor to check your belly. Because I think that's causing the nauseous. I think because it's so swollen, it's pushing up on your stomach and it's making you feel nauseous.
But, see, I used to be very active. And of course now I just don't move around unless I absolutely have to.
Yeah, but
I still make it to the bathroom.
Bless your heart.
Even if it's only to brush my teeth, I can still do that.
So the first thing is, make sure you get checked out what's causing the swelling. Second of all, for what you came here for, to treat the nausea with marijuana. So, of course, we're not going to smoke it. We're not going to inhale it. They have lollipops.
Oh, great.
Does she like lollipops?
Yeah.
I would recommend. They have little sucking candies, but they're not as easy to take out. It's nice when it's on a stick.
Okay.
And then she could just keep sucking on it until the nausea goes away.
Oh, that's great.
And then take the lollipop out, at least at the beginning, and put it aside for next time or until we figure out how much it'll take. So, lollipop.
Because some friends gave us some cookies.
Yeah.
I didn't know how to dose those.
No. The lollipops get absorbed pretty quick, and in about 15 minutes you see an effect.
Okay.
Yeah. That's one way. And she won't even know there's, you could just tell it's herbal medicine in the lollipop. There is another way that may or may not be useful. I want to tell you about it, and that's a mouth spray. And then, so then you can like dose it, like one spray in the mouth, 2 sprays in the mouth, like that. That is more medicinal, and it's a little bit harder to find.
Okay.
But one of those 2 methods would immediately relieve the nausea, and they would last about 2 to 4 hours. Okay? So that's pretty much what she needs to do. But I'm not at all comfortable with getting rid of the nausea with that swollen belly. There could be a blockage of some kind. It's really important to check it out.
Yeah.
Good work, Dr. Malka. All right, so now we're going to go to another virtual presentation, which will be Cannabis, Hemp, and Product Safety, a focus on the THC isomers by Jahan Marcu. After this, so we might go over just a little bit, but I think you all are fine with that. We will have another lunch and learn. This will not be accredited. It's going to be just the history of medical cannabis provided by Holistic Industries. So that'll be at, gotta get my time, 12:45. Figure it out. I'm looking, I got it. It'll be at 12:45 starting. Okie doke. Other than that, are we ready for the Jahan?
Hello, my name is Jahan Marcu, and welcome to my presentation, Cannabis, Hemp, and Cannabinoid Product Safety. And we're going to focus on THC isomers today. I was really hoping I could be there in person to share this with you, but something unexpected came up. I know that volunteers work really hard to put on an amazing conference, and I really appreciate that. So I try to make this one a little extra special just for the Patients at a Time group. So first off, we will start with the intro. So who am I and what am I doing? Very important questions to always check in with yourself about. So I have a PhD. I studied molecular pharmacology of cannabinoids. I've published both basic and clinical research looking at cannabis and cannabinoids. I've helped create cannabis and hemp standards for operations and product safety with groups like ASTM and the American Herbal Products Association. I'm also a court-qualified cannabis expert witness and provide advising and consulting to regulators and the industry. One of my current projects involves tracking experiences, mostly what we might call adverse events or complaints or unexpected effects from cannabis. So if you would do me this huge favor of scanning this with your phone, I will be showing this QR code throughout, but it has to do a little bit with our project, which all started with a huge uptick in Delta 8 reported adverse events. And so for the purpose of this talk, I'm going to focus on Delta 8 because it has a very interesting story. And I found this great quote from an attorney with the U.S. Hemp Roundtable that said, unfortunately, nobody that was dealing with this legislation knew what Delta 8 was. So today we're going to go through an overview. We'll discuss what do we know about Delta 8 and some of the other isomers. What are the big issues that people are focusing on? Mostly public health issues from my perspective. And we'll share what some states are coming to, and that is a consensus about the status of Delta 8 THC. And we'll dive into how these products are made and what exactly is a Delta 8 product, as well as revisiting the public health issues that have so many people concerned about products that are labeled as Delta 8. So I decided to end with the takeaway, or begin with the ending of my presentation, as it were. So some of the things I hope you take away from this presentation include that there is a need to regulate chemicals, not where they come from. So we should regulate opioids, whether they are synthesized at home or come from the poppy plant, for example. So same thing with cannabinoids that can cause impairment, intoxication, and pose other health risks. CBD can be used to synthesize or artificially derive a horde of THC isomers. And this has been known from quite some time. The World Health Organization has published some documents, which we'll discuss which precede the Delta 8 boom. Many states have started to ban synthetic, semi-synthetically derived or artificially created THC isomers. And some states are now even updating their regulations that their 0.3% THC limit includes all tetrahydrocannabinols. And there are many, many issues surrounding this gray area that Delta 8 and other THC isomers sort of float around in. And data by my colleagues and I have shown an increase in adverse events, particularly respiratory events associated with D8 THC products, not typically seen with Delta 9. As we all know, one of the things that makes Delta 9 safer than a lot of things is that it does not have, it's not associated with causing respiratory issues. So it's really troubling to see this with Delta 8 products. So let's begin with the beginning, and that is what's on a cannabis plant. So there's been reported over 500 ingredients. Not all of these compounds occur on every plant. Some different plants produce different arrays of compounds. And there are a lot of things that have yet to be identified. So for example, there's at least 9 variants of Delta 9 THC. There's at least 2 known of Delta 8 itself. We really don't know what all these different variants and isomers do. And they all have different market values. The alkaloids of the cannabis plant have yet to really be marketed and valuable. But the price of Delta 8, its novelty, has started to wear off. It started to decrease month by month in its overall price. And this may have to do with the FDA consumer update on May 4th, which warned about the risks of THC Particularly, one of the factors included adverse events reporting, which we first presented over a year ago. So if you go by the Orange Book, which is this handy dandy book that lists all drugs that are licensed, illegal, legal, scheduled, not scheduled, it does list Delta 8 explicitly as a tetrahydrocannabinol and a Schedule 1 drug. That's what that little 1 means. It's not a 3, it's a 1, tetrahydrocannabinols. So, it's a Schedule 1 drug. Many states have banned it. And now you have this competing hemp farm bill. So the truth is probably somewhere in between. But what we're really left with is that there is a chemical process used to create Delta 8 and other isomers using harsh and toxic chemicals, usually some sort of acid that it is boiled in. This process creates a lot of residual, a lot of unknown compounds, and a whole array of different tetrahydrocannabinols. So when someone makes a Delta 8 product, it might be 30% pure, 40% pure, who knows, because they may not be getting it tested by an accredited laboratory. So products being made this way are being sold in completely unregulated markets if they're obviously outside of a licensed dispensary. And this does amplify some of the risks and unknowns. There still is uncertainty regarding the legality of this product, as the hemp farm bill is being interpreted differently in different states as they're updating and clarifying their regulations. And it's not really great that the FDA and DEA have been particularly silent on clarifying this issue. The synthetic cannabinoid market could be very big, estimated to be $10 billion by 2025. And so this really suggests the need for standardizing these products, regulating these products, and actively researching them as they are isolated. But the fun doesn't stop there, because Delta 8 products can be purchased just about anywhere. Gas stations, convenience stores, even some cannabis dispensaries. So we have to make sure we're differentiating between products that are in the legal market versus those that are just being sold any old way, put into anything, and again, sold without age requirements or any other sort of qualifications. And this boom in Delta 8 is seemed to be largely attributed to the overproduction of CBD and its decrease in value. Delta 8 does not occur in significant amounts on the plant. So it is absolutely completely false that there's all natural D8 flower. What D8 flower is, or D8 cannabis is cannabis sprayed with chemicals used as a carrier for D8 THC to put it on there artificially. So it's quite concerning, because you can test and find a lot of trace chemicals on D8 flower. And we'll discuss some of that data in a minute. So states are taking different approaches. Colorado is banning any process that converts it, CBD, into any cannabinoid. Kentucky is taking similar activity. Michigan as well. New York has banned all Delta 8 and similar isomers. Law enforcement remains lax. I think states are wildly underfunded to support their own bans and enforcing them. Oregon has passed a bill as well. So the consensus is much like all cannabis products, this stuff is Schedule 1. At least 18 states at the time of recording this presentation have banned Delta 8 THC explicitly. Trade organizations have weighed in. Some are taking a firm stance against Delta 8 THC in the marketplace because of its unregulated nature. Some are taking a stance supporting it aggressively and saying that we should sell it because it's legal and we don't need to follow all the fancy regulations in the legal cannabis marketplace. But other organizations like the American Herbal Products Association, which has been around for decades, have approved guidance policy discouraging these practices because of their risks. So many years ago, the World Health Organization actually put out a document saying, you know what, we probably should not make isomers of THC. It's a bad idea to use CBD, boil it in acid, and generate all these drugs. We don't know what they do in random amounts from these processes. Some people read that and said, this is a really good, bad idea. Let's do it. So what happened is here's an example, just a snapshot of all the chemicals that you can make from boiling CBD in some sort of acid, whether it's acetic acid, vinegar, hydrochloric acid, maybe a little bit of ethanol with something else added to it. You can create different versions of CBD, different versions of THC. It's fairly hard to control this reaction. And successive rounds of purification are typically required, but it is a big controversy in the literature. And furthermore, as you are purifying and bleaching this product, or whatever they're doing to get it in a vape pen or gummy, you're also changing the nature of those products as well. So there's no known efficacy or safety data about many of these products, the HHCs, the DHC cannabinoids. In reality, has a surprising amount of detail. That's something it's like my new mantra for THC isomers. Anytime you see a claim, this is good for this is better than that, this will help you with sleep, or whatever the claim is, there should be a lot of detail there, right? There would be a clinical study, the evidence would be widely available about the product or about the cannabinoid in question. That simply isn't the case for many of these. I think almost all of these on this slide here, with the exception of CBN. As I was saying, there's a lot of different isomers. So you probably have heard of Delta 8 by now from listening to this presentation. Delta 9 is an old favorite, right? We have THC acids, we have THCV, and so on and so on. But how are people making some of these Delta 9 isomers, these Delta 8, the Delta 10s, the HHCs? Well, they buy lab kits. They're pretty simple. Many of them will just ship you everything you need, the stuff to boil it in and the other products to process it. And what happens is, for example, as reported by Chemical Engineering News of the American Chemical Society, you'll take CBD and it can get converted into Delta 8, Delta 9, and Delta 10. So this is sort of a reflux reaction with CBD in an organic solvent. They use the example of heptane or toluene sulfonic acid or other acids, and you run this and basically you close that ring on CBD up there on the left. And this is a process that's akin to making methamphetamine from cold medicine, or maybe you found a way to synthesize, opioids from CBD. We have to be careful about this logic, because just because the starting materials might be in a legal framework doesn't mean that the end product always is. And speaking of end products, here's an example of a publicly available certificate of analysis of one Delta 8 product, which has Delta 9 in it, Delta 8, THCV. And there is a fair amount of THC in these products. Again, a lot of Delta 8 products aren't very pure, maybe 70%, maybe 30%, maybe 40%. But wait, there's more. Here's a residual solvent test for some Delta 8 flower. Remember, Delta 8 flower doesn't really exist. It's good old wonderful cannabis sprayed with chemicals containing Delta 8. So it's added there. It's adulterated cannabis, essentially. And it also tests positive for the carrier that was sprayed on the plant, in this case, isopropanol. But if you act now, you could receive a bonus in your product. So another concerning thing that has popped up is the use of bleaching and bleaching agents and bleaching clays. Some, have different drawbacks, but basically what you're doing is you're changing the acidity of that product. And so that also changes how stable those compounds are, what they turn into, and things like that. So this is also another concern. Some Delta 8 companies pride themselves on not using bleaching agents, but one of the things that happens when you synthesize compounds from THC or artificially derive them, I've also heard this described as non-synthesis synthesis. So yeah, non-synthetic synthesis. And it's like non-breathing breathing. I'm not really breathing, but I'm breathing. So be careful with how you phrase it, but artificially derived products from CBD, certain reactions produce these ketone bodies, which gives it this kind of reddish, pinkish, rosé color. And that is bleached out of a lot of these products to give it this sort of clear look to it. So just to revisit some of the public health issues, at least from my perspective with these products, from a practical standpoint, there really is no safe amount of these products, because there is no guarantee of their safety. There's no oversight. There's a lack of regulation, and thousands of adverse events have been reported. And these adverse events are hard to track down, because until, that's why we created Buds Info, was to have a centralized database for reporting complaints, unexpected effects. We've even added the questions to this, like, did you get high? Did you not get high enough? What was the unexpected effect? But again, one of the things we found digging through FDA databases or the FDA affairs database was that there's a significant amount of respiratory events associated with delta-8 THC, as well as its psychoactive and intoxicating properties, at least on products labeled as delta-8 THC. And then one interesting thing about this is we found a lot of products that sometimes have upwards of 5,000% over the legal limit of 0.3% delta-9 THC. So the waters are getting a little choppy for delta-8 products. And so we did a survey. We started visiting some stores, which were pretty easy to find. You just put it into Google Maps and you put in delta-8 THC and a bunch of things pop up. So we did this because regulators didn't know how much delta-8 THC was being sold in their jurisdiction. So we went store to store. I'll just show one example in a second, but basically there were typically no purchasing restrictions or requirements were documented. Anyone of any age can come in and buy any potency or any product. Label information usually indicates delta-8 THC among other isomers being sold. No chemical information or chemical confirmation was provided, so it's hard to find COAs or other things for these products. And a lot of these products like label the amount of THC, and I'll show you one example of one that had 2 THC per serving in a bottle. So this is Le Hemp Boutique. It's a made-up hemp store. You can probably guess the name there. So there was a wide variety of isomer products and dosages found here. There were knockoff dab products, there were smokables, edibles, a wide variety of various cannabinoids and cannabinoid combinations, no purchasing restrictions. And this particular location was across the street from the fire department. And there on the right, there is a product, which I love product labeling. So here we have 33 milligrams of delta-8, 2 milligrams of delta-9, and then a mysterious 300 milligrams total cannabinoids. Is it CBD? Is it THC? Do they just not know what it is? There's just all this extra stuff there. So at least they told you what 2 of the things in the product were. So as we think about what are the risks to artificially derived delta-8 THC, well, we don't know what the long-term effects are. There are some indications that there are significant risks to using these products, but again, it's really in its infancy. People put out these products and are like, there are no side effects. That's because no one's studied it and no one's tracking it, or no one is looking in the right place for these. So what do retailers say about their products? So for example, manufacturers will say that consumers find delta-8 THC, to present pleasant potency or efficacy. Again, reality has a lot of details, so there should be some information, you'd think, to back this up for you to look at, read some sort of survey with lots of people. They also say things like, you do not experience quite the psychoactivity or impairment. They also might say something like a generally lighter experience for consumers. And then their marketing material, for example, shows someone passed out on the couch from using their product. This is actual delta-8 commercial products. And so when you go into data that's coming in from poison control centers and going into the FAIRS database, which is, again, very difficult to navigate and track, as again, everything is decentralized state by state usually, we see some things that are really interesting. A little bit less than 20% of the cases that we documented and went through were dyspnea. There was a lot of drug interaction and drug issues related to delta-8. So people were showing up with not just one drug in their system, but delta-8 was a thing that brought them into the ER or to contact a clinician because of the effect. The thing that is most concerning to me was respiratory disorders, making up over 10% of our data so far. We've just tabulated the data and we'll be presenting our data at the International Cannabinoid Research Society meeting in Galway and have submitted our paper for publication, which has a much more extensive analysis. We also see some things you might expect from an unregulated product that contains an intoxicant, vomiting, dizziness, feeling abnormal. Some other concerning things include seizures and things like that being reported. So not great to have respiratory issues and disorders being reported along with dyspnea. So these are, again, probably why the DEA has put out these warnings and states are banning it, is these adverse effects that really have not reached national news. So, as we reach the end of this presentation, I just want to revisit some of the public health issues. And many of the public health issues for delta-8 THC have downstream implications for many of the other isomers that are out there. So again, from a practical standpoint, just because you don't know about the adverse events of a product doesn't mean they're not out there. Don't assume the purity of these products, as there's lots of adverse events coming in, and as we get more and more information because of those products become known that are associated with this adverse events can potentially be analyzed. So again, I think the most important thing here is that a lot of these products often involve the use of chemicals to create concentrations of Delta 8, and these produce a lot of byproducts. So the next steps include for you, the viewer and listener of this presentation, to be cautious about unregulated products. They don't test these products, they test them on you or your loved ones, whoever is accessing these products. There are no age limits for these products, and you should really avoid any product or industry where your safety is not a priority, where product safety is not a priority. And it's typically not a priority in illicit markets, historically speaking. FAERS, the FDA Adverse Events Reporting System, is our only national sentinel system for all products. And Delta 8 was just added about a year or so ago. So there's been, again, they haven't been tracking it very long. There's already been a huge increase, and nobody really knows about this system. There's a lot of education about it. So for it to reach the FDA database, it had to be such a significant experience that clinicians or the consumer went looking for a place to report it. So these results are significant. So we designed budsinfo.com with my colleagues to hopefully create an easier, more centralized system. So please check it out. Let us know what you think. We're trying to improve it and develop it. We're also working with companies to create their own adverse event tracking systems for their products. Again, making it user-friendly, easy to use, and as simple as possible. We desperately need information on Delta 10, THCO acetate, and any of the other hodgepodge of chemicals that people are creating. So a little bit of summary is Delta 8 THC's pharmacology from the textbook, from scientific literature, is nearly identical to Delta 9 THC. Delta 8 and its isomers are produced through synthetic chemistry that converts CBD, found in legal hemp, and basically puts it in this regulatory void. There's been a rapid increase in the popularity of these isomers since the passage of the Hemp Farm Bill. And again, Delta 8 is just one of the many synthetically derived cannabinoids of concern. And again, if this is not addressed from a holistic standpoint, this will just be one of the many compounds that businesses will create and market. And remember, the playbook is already out there. The World Health Organization reports saying, don't do this. This is how you do this. Don't do this. This is what we should be careful of. People are using that as a playbook to move forward with product development for generally unregulated spaces. So common sense solutions do exist for this to proactively address how products are evaluated, how to keep consumers safe without adversely impacting business and the global supply chain. So to close, I want to share some quotes. I'm not sure if I regret saying yet. Time will tell. But one of them is all these loopholes for these isomers are going to close. And loopholes turn into nooses. So I think there are going to be a lot of people who are in these loopholes who are not going to be comfortable. If you get caught with a bunch of Delta 8 products, how can you prove it's from hemp? There's no test for that. As an expert witness, I've been involved in really kind of sad employment cases where people just believed what was ever on the package. And it really did not work out to their benefit. So it's to me, it's like these producers of hemp products and Delta 8 THC, these isomer products, decided to strap consumers to the front of a train and said, go have fun with your collision with law enforcement. We're done here after this transaction. So feel free to debate me. You might be able to change my mind. So if you've enjoyed some of the artwork that's been here, this is from my podcast, How to Launch an Industry, as well as from some of my own nature pictures. So please check that out. I'm happy to answer any questions by email, jahan@marcu-aurora.com. I'm also visible on social media. So please check out the Cannabis and Hemp AE tool and look forward to hearing from you.